Very good evening to all of you. And first of all, I would like to congratulate BOS and especially Sangamitra for conducting this program. Yesterday, it went very well. Unfortunately, I was busy with some other commitment, but I am sure today it will be great also. So for first case, I invite Dr. Sandeep Diwan sir. He doesn't need any introduction. Sir is well-known national as well as international faculty, and Sandeep sir's fellow Dr. Naveen will be going to present the case for TKR. Sir, please.
Thank you, Hetalji. So, Dr. Naveen, you can start.
Yes, sir. So, good evening, everyone. So, today my topic of presentation will be a case on TKR. Just a brief history. An 80-year-old female who has presented to the OPD with complaints of pain in both the knee joints, has diagnosed to have an osteoarthritis of the bilateral knee joints, and posted for a unilateral TKR. The patient is a known diabetic and a hypertensive on medications. Significant lab investigations were HbA1c was 7.2 percentage with a FBS of fasting blood sugar of 128 milligram per deciliter. And previous surgical history, she has a previous history of operated lumbar spine decomp plus stabilization has been done. Where this is the clinical X-ray of the patient of the right clinical X-ray of the patient of the right knee, where we can see posterior osteophytes, which has been present. Uh, so this is a posterior osteophytes has been present on the right side of the knee and is planned for right side TKR. And this is the significant spine examination where on local examination there was a vertical scar which has been present at L4 to S1 level. And on palpation there was a scoliosis at L3 to L5 along with an interspinal space which was palpable at L1, L2, L3, L4 and L3, L4 levels. Yes, sir.
So, thank you, Naveen, for this. So, let me know what would be your take on this. Like, how would you want to go?
Sir, so regarding this, we have to plan for the regional anesthesia strategy for this patient based on her comorbidities and the previous or history of operated spine. So since the patient has a previous history of operated spine, I will like to get a spine and a neurologist opinion regarding whether there is any sensory motor neuro deficit for this patient, whether the patient is fit enough to undergo a spinal anesthesia. If yes, then I will plan ahead with the spinal anesthesia with a peripheral nerve block for post-op analgesia. And if not, I will go ahead with the general anesthesia with a preoperative peripheral nerve block for this patient.
So, what will distinguish that you'll be going in for a general anesthetic technique or a regional anesthetic technique, like a spinal or a general anesthetic technique?
So since the patient has a previous history of operated spine, I would like to assess the sensory motor deficit. If there is any deficit, if there is any patient weakness is there, I'd like to get a neuro and spine surgeon's opinion on this, sir, whether the patient is fit enough to go undergo a spinal. So, hello, sir.
So, for the general anesthesia technique, whether the peripheral nerve block would be prior to the surgery or after the surgery, like for the spinal anesthetic.
Sir, for the spinal anesthesia, I will plan the peripheral nerve block after the surgery, sir. For the general anesthesia technique, I'll like to give the peripheral nerve block prior to surgery, sir.
So, would there be any differentiation between the approaches for the general anesthetic technique and the spinal anesthetic technique regarding the peripheral nerve block?
Sir, so with the spinal anesthesia technique, we are completely blocking the sympathetic and the sensory input, sir. So the block which can be given post-operatively is pre-operative and post-operative blocks is of similar equivalence, sir. But in general anesthesia, pre-operative better analgesia intra-op, sir.
So, intraoperatively, do you mean to say that you would be going more proximal with general anesthesia technique, and with spinal it would be more distal?
Yes, sir. With a general anesthesia technique, I'll talk to the surgeon when he wants to mobilize the patient, sir. If he is planning to mobilize the patient after 24 hours, I would like to go more proximal and give a femoral nerve block for this total knee replacement, sir.
And why this differentiation? With the general anesthetic technique, you're going more proximal, while with spinal, going more distal.
No, sir. With general anesthesia, we can go more distal, sir. But anyways, I'll have a word with the surgeon, sir, when he wants to mobilize the patient. If he wants an early mobilization, then I'll go ahead with the proximal adductor canal block, even with the general anesthesia technique, sir, along with other local infiltration analgesia, IPAC, and multimodal analgesia, sir.
I would like to say that with the more proximal technique like the femoral nerve block, it is more of a neural target. While with the adductor canal block, it's more like a facial plane target where the nerves might be have a lot of variations in the canal itself. That is the reason why I would prefer with just That's why I would prefer more of a more proximal technique like the femoral nerve block, as you rightly said, with the consultation of the surgeon as well as with the counseling of the patient regarding the mobilization.
Yes, sir.
Regarding the peripheral nerve blocks, what would be the your approach?
Sir, so since this patient in the clinical X-ray of the knee that has a lot of posterior osteophytes, so which denotes that the patient will undergo more of a posterior dissection, sir. So the peripheral nerve block which I will want to select for this patient will be an adductor canal block with a IPAC block, sir. And if the patient has more of a fixed flexion deformity or more of a valgus deformity, I'll add on with the local infiltration analgesia for this patient as well, sir.
So let me come to the local infiltration anesthesia. Now, in the total knee replacement, most of the nociceptors are removed.
Yes,
So
sir.
with the nociceptors removed, like for example, the infrapatellar pad of fat, then the synovium, the menisci, which are less neural targets, and as well as the anterior and the posterior cruciate ligaments, all of them have been removed. So where the pain originates from?
Sir, there are two sources of pain after a post knee replacement, sir. One is by the A delta fibers, which carries the pain, sharp pain from the incision side, sir, the dermatomal pain. And second is by the C fibers, which carry the pain from the increase in the intramedullary pressure from the bone marrow drilling. And there is a bone cement interface where it causes the exothermic reaction that has an effect on the free nerve ending, sir. So that will cause more of a dull pain, sir. And the sharp pain is because of the incision side.
So you mean to say that in spite of removing all the painful structures, the patient still persists of pain basically because of the skin incision and the subacute and the muscle retractions,
Yes,
right?
sir. And yes, sir.
Yeah. So now, if this is the case where the skin and the subcutaneous tissue is more innervated by the cutaneous nerves, why not give a local infiltration quite successfully in all the compartments and include a cutaneous nerve block? That's all, and don't give adductor canal and IPAC. Does it suffice?
No, sir. So this local infiltration analgesia is given by the surgeon himself, sir. So in view of the posterior neurovascular structures, the posterior capsule is not being infiltrated adequately by the surgeon, sir. So that will require an IPAC block, which is given by the anesthesiologist.
So do you mean to say that the LI is insufficient and it has to be combined with the IPAC, or it has to be replaced with IPAC? What is it like?
Sir, no, sir. It has to be combined with IPAC, sir.
So you mean to say that LI, IPAC, and the cutaneous nerve blocks would suffice in this case?
So cutaneous nerve block in the sense the adductor canal block will suffice. Yes, sir.
No, I'm asking you about only the cutaneous nerves, the intermediate and the medial cutaneous nerve of thigh.
No, sir. Adductor, the saphenous nerve block will also be required. So saphenous nerve block along with the nerve to vastus medialis, which is blocked in the proximal adductor canal, is required, sir.
Okay. Now, for the benefit of the the delegates, can you just highlight what is this periarticular local anesthesia infiltration?
Yes, sir. So this is a periarticular LIA cocktail, sir, where 100 ml of local dilute local anesthetic is being injected, and it comes in various compositions. So we give the final concentration of bupivacaine will be 0.1% along with a opioid which is morphine, adrenaline, and a steroid ketorolac as well. And this is being infiltrated, which is before cementing and after cementing, sir. So initially they will infiltrate the posterior capsule and then the lateral and the medial collateral ligaments. And then after cementing, they will infiltrate the patellar quadriceps tendon and the prepatellar area, sir, and the subcutaneous tissues. So total 100 ml of volume is being injected in the periarticular LI.
Okay, so why so many of molecules are involved in this? Why not just include just bupivacaine or maybe with or just bupivacaine? That's all. Why not? Why?
Sir, 100 ml of local anesthetic, only bupivacaine. So we are adding adrenaline in the view of decreasing the vascular uptake or systemic absorption of the local anesthetic, one, sir, and it decreases the bleeding per se and the surgical field, second, and adding opioids such as morphine. In this case, recent studies have showed that the morphine has no significance. The local infiltration analgesia without morphine and the LIA with morphine gives equivalent analgesia. And adding ketorolac, which is NSAIDs, it also helps in decreasing the inflammation and it decreases the post-operative pain in this patient, sir. And adding dexamethasone 8 to 10 milligram also helps in decreasing the inflammation and decreasing the pain post-operatively.
So you mean to say they are all evidence based except morphine, which should not be used at all, right?
Yes, sir. Recent evidence shows morphine has no significant role. Yes, sir.
Okay. Now once you give a local anesthesia infiltration, how many hours it would last? Just the
Sir,
LI.
LIA, it will last around 6 to 7 to 8 hours, sir.
Okay. So and then you would like to combine it with IPAC, right?
Yes, sir.
So why IPAC? Like, can we just briefly narrate what the IPAC is, what the technique is, and
Okay, sir.
what volume of local anesthetic is used? What are the injection points?
Yes, sir. Sir, so basically, IPAC is given in between the posterior capsule of the knee and the popliteal artery, sir. So they are targeting the posterior popliteal plexus. The popliteal plexus is formed by the posterior branch of the obturator, the common branches from the common peroneal and branches from the tibial nerve, sir. So these structures can be blocked by giving an IPAC block, where the IPAC can be given proximally as well as distally. The proximal IPAC is at the level of the distal shaft of the femur, and the distal IPAC is at the level of the intercondylar notch, sir. So this targets the popliteal plexus, which supplies the posterior capsule of the knee.
You
And
you just mentioned about two approaches. One is the shaft and the other is the condyle. So what is the difference between these two?
Sir, the proximal IPAC, which is being given around volume of 15 to 20 ml, so the drug can travel to the distal adductor canal as well, and it gives more of a medial genicular blockade, sir. Whereas the distal IPAC, it gives more of a lateral genicular blockade, and it does not have any proximal spread. It just localized to the popliteal plexus alone, sir.
Okay, so now you mean to say that if you give it in a more proximal area, the drug would likely to be spread in the distal adductor canal and would block the medial genicular nerve.
Yes, sir. Yes, sir. It will not block the saphenous nerve, sir, but it will the drug will spread to the distal adductor canal.
So what is the importance of spreading to the distal adductor canal and blocking the medial genicular nerve? What would be the importance?
Sir, because the medial genicular nerve, the maximum nociceptors are present in the anterior capsule, that too in the medial compartment, sir. So targeting the medial compartment nociceptors is important for postoperative better analgesia.
So now you have confined yourself to the anteromedial aspect of the knee joint, which has got maximum nociceptors, right?
Yes, sir. Yes, sir.
Yeah, okay. Now, if I choose to give a LIA of high concentrations only at the anteromedial aspect of the joint, right?
Yes, sir.
And along with the IPAC, because in this patient has got posterior osteophytes as well. Would it suffice?
No, sir.
What would be the reason?
So this infiltration, the local LIA which has been given in the anteromedial compartment will give only localized anesthesia, sir, to that site, operative site. But whereas the muscle retractions which has been done and the nerves, the nerve to vastus medialis and the proximal saphenous nerve which comes down also carries the pain impulses, sir. So it has to be blocked a little proximal.
You mean to say the LIA and the proximal IPAC is not going to suffice. So anything else
Yes,
that
sir.
you would like to add in this case?
Sir, I would like to go ahead with the saphenous nerve block, which is at the level of the proximal adductor canal, sir.
But what's the use of blocking the saphenous nerve? I think the saphenous nerve just courses the adductor canal without contributing much to the knee joint. It will
Yes,
just give the infrapatellar branch, which is the branch to the Hoffman's pad of fat, which has got the highest density of nociceptors, which is of course removed during the surgery.
yes, sir.
Then,
Sir, blocking the nerve to vastus medialis, which does not lie in the true adductor canal, but lies in a separate muscular compartment. So that has to be blocked, sir.
so now you mean to say that these both nerves have to be blocked.
Yes,
So
sir.
how would the saphenous nerve contribute towards the knee joint innervation? In what way it would contribute?
So the saphenous nerve that gives the cutaneous innervation, sir. So that will take care of the dermatomal pain. And as you said, it has gives the infrapatellar branch to the Hoffman's pad of fat, which has been removed, but still there will be free nerve endings in that, sir. So giving a saphenous nerve block will take care of the dermatomal pain.
Right. Not only that, but there is a strong evidence now that the nerve to vastus medialis has got the maximum innervation to the knee joint on the anteromedial aspect. The saphenous nerve has got a moderate evidence because it on anastomosis with the nerve to vastus medialis forming a deep plexus.
Deep
Okay,
plexus.
from which
Yes, sir.
arises the medial genicular nerve or the medial retinacular nerve,
Yes, sir.
and also the saphenous nerve possibly anastomosis with the anterobturator nerve,
So,
forming what?
uh,
It forms the
saphenous
subsartorial plexus.
subsartorial plexus. Yes, sir.
Yes. So these are the possibilities of the plexuses in the adductor canal, right?
Yes, sir.
Okay. Can you now briefly mention about the adductor canal, the anatomy, the topography, the various compartments, the volume of local anesthetic used, the concentration used?
Yes, sir. Uh, Sir, yes, sir. So the adductor canal basically it extends from the apex of the distal femoral triangle, sir. That is the confluence of the medial borders of the sartorius and the adductor longus until the adductor hiatus, sir. So as we can see, this is the adductor canal which is formed by the sartorius, which is anteriorly, and adductor longus and adductor magnus, and the nerve to vastus medialis. Where this is the neurovascular sheath which encloses the femoral artery, vein, and the saphenous nerve, which forms the true adductor canal. And this red structure is the vasoadductor membrane, sir. So this article suggests that there are total five compartments. So this is the subsartorial compartment above the vasoadductor membrane. And number two is the compartment which is outside the neurovascular sheath but in the adductor canal. And number three, which is the within the true adductor canal. So, and number four, which is again outside and more medially towards outside the neurovascular sheath. And number five is posterior and outside the neurovascular sheath, sir.
So in these compartments, which compartments are of use for us, and which would you, disregard?
Sir, the compartment number three, sir, which is the true, which forms the true adductor canal, so the neurovascular sheath. So this is where the saphenous nerve lies, sir. And number two is the second is giving the nerve to vastus medialis block.
So the nerve to vastus medialis lies in a separate compartment, which is ensheathed with the sheath of the vastus medialis muscle, right?
Yes, sir.
And it's always present below the vasoadductor membrane
Yes, sir.
in the adductor canal. So prior to the adductor canal, it can be outside it can be above the beginning of the vasoadductor membrane, but lower down in the adductor canal, it's always below the vasoadductor membrane, right?
Yes, sir. Yes, sir.
So now, what are the approaches like which has been mentioned in the literature, and what you would use in this case?
Sir, I would like to go ahead with the proximal adductor canal block, sir. So by using an ultrasound technique where I would like to place my high frequency linear probe on the anteromedial thigh and identify the confluence of the medial borders of sartorius and the adductor longus. And caudal to that, I would like to identify the femoral artery, sir, and the saphenous nerve, which is lateral to it.
Okay. And what volume and concentration you would like to be used?
So since it is a post-operative, since it is for the post-operative analgesia, I would like to use either zero point 0.2 or 0.375% ropivacaine, and volume is around 15 to 20 mLs of local anesthetic, sir. So 15 mLs for the saphenous nerve I'll give, sir, and then 5 ml I can infiltrate. I mean, I can inject around the nerve to vastus medialis. So total volume of 20 mLs.
Is there a possibility that you inject right into the true adductor canal, that is the one where the saphenous and the vascular structure lies, and there would be a diffusion into the nerve to vastus medialis? Is there
Yes,
any
sir.
possibility?
Yes, sir. So when injecting around 15 to 20 mLs of local anesthetic within the through adductor canal, we have seen in dynamic scan that the drug diffuses and reaches the nerve to vastus medialis as well as the subsartorial compartment as well, sir.
That video, can you show that? Is there a possibility of the video?
Uh, no, sir, that video is not playing in this, sir. Uh, Sir, this is after injection. So this is not a video, but a clip, a picture which has been taken where after injection, we can see the drug around the saphenous nerve and there's diffusion of drug around the nerve to vastus medialis as well, sir.
So is this with a single puncture?
That's with a single puncture, sir. Only if single puncture, needle is placed lateral to the nerve and injected, sir. And after 20 mLs of local anesthetic, the drug has diffused around the engulfed the saphenous nerve as well as the drug has diffused towards the nerve to vastus medialis.
Okay. So now you do this block. So anything else that you would like to add into this?
Sir, sometimes a post-operative patient might complain of pain even after getting an adductor canal along with an IPAC, along with an LIA, sir. So there can be sparing of the anterior cutaneous nerves as well. So
So
blocking the, yes, sir.
yeah, please go ahead.
Yes, sir. So blocking the anterior cutaneous nerves, which are the anterior, medial, and the intermediate cutaneous nerves, also help in giving a complete dermatomal pain relief for these patients, sir.
Yeah. So is this a video? I think it's a video, or it's just an image.
It's a video, sir. So this the drug is being injected lateral to the saphenous nerve, sir, and then while separate injection can also be given to the nerve to vastus medialis if on dynamic scan the nerve to vastus medialis is not being soaked, and and while withdrawing the needle, a separate subcutaneous infiltration can be given over the sartorius muscle, sir, in order to cover the medial femoral cutaneous nerve.
Okay, and what about the other nerve? What is this? The other?
Sir, So this in this video, we can see that with a single nerve, with single point injection, we will give the saphenous nerve to vastus medialis, medial femoral cutaneous, and then withdraw the needle, come middle laterally, and give the intermediate femoral cutaneous nerves as well, sir.
This video is not proper. It looks vertical.
Yes, sir.
So that has to be corrected prior to your presentation, no?
Yes, sir. Sorry.
Okay, anyway, so we have got now finally we have the saphenous nerve, the nerve to vastus medialis, the medial cutaneous nerve of I mean the middle femoral cutaneous and the intermediate femoral cutaneous. So of these, the
Mhm.
NVM has got a robust evidence. The saphenous nerve has got moderate evidence. The anterior obturator nerve, which might contribute towards the plexus along with the saphenous nerve,
Subsartorial
the
plexus. Yes, sir.
subsartorial plexus. That's hardly 11%, and that's also mentioned only once in the literature. So I mean that can be ignored actually, and we haven't seen much of the cadaveric in my cadaveric studies. At least I have seen at least two uh, plexuses formed by the saphenous and the anterior obturator nerve, one in the mid of the adductor canal and one in the distal of the adductor canal. So it entirely depends upon the obturator nerve whether to form a plexus or not. If it is very much thick nerve right in the beginning, in the proximal part, it will come until the terminal and it will anastomose. If it is thin nerve right in the proximal area, it will just fizzle out into the musculature and it will never come into the canal.
Yes, sir.
And then you have medial femoral cutaneous nerve as well as the intermediate femoral cutaneous
Intermediate
nerve.
femoral cutaneous.
All these things can be covered with one single point of injection, and there's no necessity of multiple injection at various sites. Now, in case of patients having bilateral total knee replacements, what would be your approach?
So for bilateral total knee replacement, I will again go ahead with if it is a patient does not have much of a deformity or a posterior osteophytes, I'll go ahead with bilateral adductor canal block for these patients, sir.
So now you have reduced your strategy just to the bilateral adductor canal block without a bilateral LI and IPAC, or are we going to use everything together?
Uh, Sir, no, sir. Everything together, we have to calculate the maximum dose required for the patient, sir. If it exceeds the toxic dose, then we'll have to reduce it, sir. And also depends on the surgical procedure as well. If it's more of a posterior dissection, if the patient has more of a valgus and a fixed infection deformity, then it requires infiltration with LIA bilaterally, sir. So for that, we can go ahead more proximal and give an epidural, sir.
So you got two choices: a bilateral adductor canal blocks, which is more towards the proximal area, and you have the another one, which is the epidural infusions. So you
Yes,
have
sir.
come across some problems with both the
Yes, sir.
yeah. So what are these
Sir,
problems like we have
yes, sir.
faced?
So there was, so this is one patient who underwent bilateral TKR. So we have given an epidural for this patient, sir. But post-operative patient had unilateral quadriceps weakness. So on further investigation on MRI, it showed that the catheter got migrated to unilateral on the left side, sir. So only that side received all the local concentration, causing a post-operative quadriceps weakness. And the second is this patient underwent a bilateral TKR where we have given a distal femoral triangle block for this patient. This patient was a known diabetic with a HbA1c of 7.8%. And this patient post-op, after 24 hours, complained of quadriceps weakness along with a sensory deficit on the anteromedial thigh, which we have mapped, sir. And so probably this is because of the double crush syndrome or double crush syndrome, sir, because patient already has a under diabetes, and upon that we have given a nerve block. So this was resolved after starting the patient on low dose of steroids.
Right. So probably the concentration of the local anesthetic could have been reduced in this case. That would have not triggered this quadriceps weakness, which was bilateral, of course.
Yes.
And in the epidural catheter migration, actually, this is the coronal section, but in the axial section, you could nicely see the local anesthetic going around the lumbar plexus. So, in fact, in many of the times, we see that the patients who have come out of the quadriceps victis, the catheter is being removed. The patients are sent home with the local anesthetic still around the lumbar plexus, and I still fear that in the post-operative period, there might be a time when the patient buckles because of quadriceps weakness. It may be just one single time, but the patient might have to pay for it. So you have to be very, very cautious when sending these patients home even when the epidural catheter has been removed.
Yes,
Okay,
sir.
now between the concentrations of local anesthetic, did you find in all this 1 year of your fellowship, did you find varying concentrations having differential effects, decrease in some rebound pain, increase in cortisol weakness, like?
Yes, sir. So initially we were using in our institute we were using 0.2% ropivacaine with clonidine, sir. So these patients had a rebound pain at around 16 to 18 hours. But the patients after we started using 0.375% ropivacaine, the incidence of rebound pain has reduced, sir. So the initially with 0.2% it was around somewhere 33%, sir. And after using 0.375 ropivacaine along with dexamethasone, the incidence has come down to 15%, sir.
So it means that if increase the concentrations and you add dexamethasone as an adjuvant, it's going to help in increasing the or decreasing the incidence of rebound pain.
Yes, sir.
Okay. So this, I think we'll have to have a controlled trial. Unless you have a controlled trial and statistical analysis, you may not be able to understand its significance. And both, like clinically significant and statistically significance. Only then we will be able to understand this. Now, apart from this, are there any other techniques which have been reported?
So sorry, sir. Any other techniques? As
Other
we have
approaches, yeah.
Sir. So we have other hybrid blocks for this TKR, sir. So the some of the blocks are we have the dual subsartorial block where there is it's a 2-point injection, sir, where we give around 10 ml of local anesthetic in distal femoral triangle in order to cover the saphenous and the nerve to vastus medialis, and we give 20 ml of local anesthetic in the proximal adductor canal in order to cover the popliteal plexus. And we have the high pack block where there is a high volume of local anesthetic which has been used from the proximal adductor canal around 40 ml, sir. And there is 4-in-1 and modified 4-in-1 block, where in the modified 4-in-1 block, there are 2-point injections where with a single entry, we give around 5 ml of local anesthetic above the vasoadductor membrane and 15 ml below the vasoadductor membrane so that the drug seeps in and goes, enters the adductor hiatus and covers the popliteal plexus.
Okay. Now, you said it shows that here the VAM. Can you just briefly tell me what is this VAM?
So the vasoadductor membrane is a musculo-aponeurotic layer, sir, which is between the vastus medialis and the adductor longus, sir. So this extends, this forms the roof of the adductor canal, sir.
Okay. What is its significance like?
Sir, so as far as I have read, the vasoadductor membrane gives more stability, sir, more stability and to the medial aspect of the thigh, because it joins the adductor vastus medialis along with the adductor longus, sir.
So there's an entire article which is devoted to just the vasoadductor membrane, and interested delegates should really read about this. The vasoadductor membrane, which is what? Is it thicker or thinner in the initial part, proximal part, and then and how it is in the distal part?
So proximally, the vasoadductor membrane is thin, and further distally, it becomes thicker, sir.
What is its significance?
Uh, Sir, I feel that as we go more distally, the adductor canal reduces in size and the muscles which come closer. So that is why the vasoadductor membrane is thicker distally and it's far more thinner proximally, sir.
So that's one thing. And the second thing is also when you start injecting local anesthetic, you will find that the drug migrates from the adductor canal into the subsarterial compartment
Yes,
that
sir.
is below the sartorius and superficial to the vasoadductor membrane.
Vasoadductor
That is
membrane.
because there could be some fenestrations, pores, and capillaries and communications which would help in migration. Is there any significance of this compartment which has been mentioned in literature?
The subsartorial compartment, sir.
Yes.
Sir, the subsartorial compartment has the subsartorial plexus, sir. So these plexus are formed from the branches from the saphenous, the nerve to vastus medialis, the medial cutaneous nerve of thigh, and sometimes the anterior obturator nerve as well, sir.
Yeah, so I believe that the branches of the saphenous nerve, the branches from the nerve to vastus medialis, and also the medial cutaneous nerve of thigh, that there's a possibility, but very less likely that the anterior obturator nerve would come all the way from the medial aspect on into the adductor canal. That's very less likely. I mean, into the subsartorial compartment, but it can anastomose with the saphenous nerve, but may not be with the main nerves.
Okay, sir.
Now, just a few points about the just because we almost just hardly 2 minutes left. Something on the continuous blocks, catheter blocks. Do you do that
Yes, sir.
techniques?
Sir, we don't do it in our institute, sir, because this continuous catheter, one, there can be risk of catheter infection because we go ahead with a no catheter technique for all the TKR patient where there is no Foley's catheter. We don't keep IV lines more than 3 days, sir. So, and we don't keep any other catheters, epidural also. So that is why we prefer more of a distal blocks rather than going for an epidural, sir, to reduce the risk of infection.
So it is just
And
like a catheterless technique where you don't use any catheters, even for the bilateral blocks. Usually no epidurals, no Foley's catheters, and the patients are mobilized as early as possible. Is it right?
yes, sir.
Okay. Anything else to be discussed? If
Uh,
any questions, we got half a minute.
Sir, so a few interesting cases that
Yeah,
we
you
have
can
done
just
in
show
our
them. Yes,
institute.
yes.
Yes, sir. So this was a stage TKR which was done where the patient had a case of rheumatoid arthritis, the COPD on BiPAP, and an ischemic heart disease with the EF of 30 to 35%. So we performed this case with stage TKR. We did it along with the combined spinal epidural where we gave around hardly 0.8 to 1 ml of 0.5% hyperbaric bupivacaine along with the epidural. So after the supine position, we flushed the epidural with 1 ml of saline, and that gave a level up to T10, sir. So immediately post of the patient, patient started. patient started mobilizing and moving her lip soon immediately after the surgery, sir. So this will give a better hemodynamic stability for this patient rather than going ahead with only single short spinal, sir.
Next.
And this was a case of a tumor implant of the knee. So the regional anesthesia technique has to be also decided whether what type of surgery has been planned for the patient, sir, because this is a very extensive surgery where the bones have been removed and there is a lot of muscular dissection going on. And so for this, the regional anesthesia technique will be a general anesthesia with an epidural anesthesia, so to better to maintain a better hemodynamics for the patient. And finally, the ERAS protocol, sir, where the ERAS protocol and the prospect recommendations, where in regional anesthesia technique, they are telling a single shot adductor canal block with the periarticular injection will suffice for this patient, along with the other systemic analgesics, IV dexamethasone, and opioids, sir, as a rescue
Thank you very
analysis.
much, Dr. Naveen. Thanks, Hetal. Thanks, Sangamitra. And thank you, boss.
Thank you, sir.
TOS.
Thank you so much, sir.
Thank you, Sandeep sir, and well done, Naveen.
Thank you, sir. Thank you, ma'am.
So moving ahead with today's next topic, it is a case discussion on midline laparotomy with Shiva Shanmugam sir and Dr. Parvati. I would, Parvati, can you please share your PPT?
Sangamitra, am I audible?
Yes, sir. Yes, sir. Good evening, sir.
Okay. Thank you. Good evening, everyone.
Ma'am, is my screen visible, ma'am?
Yes, can you make it full screen?
Yes.
Thank you.
Good evening, everyone. My case is a midline laparotomy case, and I'm Dr. Parvati, and the moderator for the session will be Dr. Shiva Shanmugam, sir. My case is a 51-year male patient. He's a case of carcinoma rectum. His status post chemo and radiotherapy, and he has previously undergone laparoscopic low anterior resection also. He is currently posted for open anterior perineal resection with bilateral iliac lymph node dissection. The patient came with a history of bleeding per rectum for 1 year. He also had history of constipation, incomplete evacuation of stools, and there was mucus discharge per rectum also. And he also gave history of loss of appetite and significant weight loss over past 3 months. There was no history of difficulty in defecation, tenesmus, jaundice, bone pain, or abdominal distension. Patient had received chemo radiotherapy and also underwent laparoscopic LAR in May this year. And his post-op biopsy showed residual adenocarcinoma. So he has again received capox chemotherapy, and a colonoscopy after the chemotherapy showed a growth at the anastomotic site. So he's posted for open surgery now. General examination of the patient. He is conscious oriented. There is no pallor, icterus, cyanosis, clubbing, or lymphadenopathy or edema. He is a moderately built patient with 76 kgs and a height of 172 centimeter and a BMI of 25.6 kg per meter square. His vitals were stable with pulse rate 98 beats per minute and a BP of 152 by 82 millimeter of mercury and room air saturation of 97%. Cardiovascular system showed no abnormalities. S1, S2 were heard and there were no murmurs. Respiratory system showed bilateral air entry equal with no added sounds. Airway examination showed mouth opening of 3 finger breaths and a Mallampati grading of 3. Mandibular subluxation was present and full range neck movements were possible. Midline of the spine was palpable. There were no abnormalities noted and there were no skin lesions also. Investigations wise, there was no gross abnormalities. Complete blood counts were okay. Hemoglobin of 11.5 gram per deciliter, total counts of 7,000, and a platelets of 1.9 lakhs. Blood urea was 25 and creatinine was 0.79. And electrolytes were also normal with sodium 141, potassium 4.45, and HbA1c was 9. The comorbidities of the patient, he was a known diabetic and hypertension, both under control. There were no abnormalities in the electrocardiogram. The echo study was normal and the chest x-ray also was within normal limits. My regional anesthesia plan for this patient will be a multimodal analgesia along with general anesthesia for the patient.
Uh, okay, Parvati. Now, I request to all the fellows. So here we are going to demonstrate to you a discussion about your anesthesia care plan for a midline laparotomy. So whenever in exam, what we are expecting is your anesthesia care plan. Don't think it is only a regional anesthesia care plan. So my request to all the fellows or recommendation to all the fellows is what we were interested to know is about how you are going to manage this patient as a whole. Don't think that we will discuss only the regional anesthesia. Okay, having said that, when we look at the case presentation, it looks like a middle-aged adult without much of comorbidities and normal investigations. Lean patients looks like easy regional targets. Posted for a midline laparotomy, we can see the images and see the patient as well, how he was in the post-op. So I request Parvati, what is your anesthesia care plan? Being it's a regional anesthesia fellowship, I wanted to look at what's your strategy for this gentleman.
So my care plan would be for to give general anesthesia for the patient along with multimodal analgesia, which includes lower thoracic epidural analgesia and multimodal analgesia, which also includes injection paracetamol and NSAIDs also for the patient, sir.
Okay, my question, or when you have an effective epidural that is working, do you think what is the role of other drugs would play in this particular patients? For example, if you achieve a good level, for example, from T6, for in this individual, the incision is little above the umbilicus to the symphysis pubis. If you get an effective spread of T5 to T12, do you think what is the role of this multimodal analgesia?
Sir, multimodal analgesia, because when there is a surgical stress response, there is also inflammation going on for the patient. So, adding multimodal analgesia with anti-inflammatory, NSAIDs like COX inhibitors like paracetamol or ketorolac will help decrease the inflammatory response, which will help the patient to improve better in the post-operative period also, sir. So the
So
surgical
in the
insult to the
multimodal,
patient is decreased. And also considering this patient is posted for open APR, which also includes perineal resection, and the sacral segments are also involved. So the epidural may not have adequate coverage for that. So that will be covered with the multimodal analgesia, sir.
okay. When you say multimodal, many a time we discuss about multimodal. What are all those modalities that you are looking for? One is epidural. I can understand it's a local and NSAID. And what else that you wanted to include into that? What do you mean by that?
So when coming to multimodal analgesia, we have to see what are the different techniques we can give. Intravenous drugs will include paracetamol, NSAIDs, and opioids, and which is a climb up along the ladder. So there is rescue opioid analgesia that can be given if other techniques have not covered the pain adequately. Coming to the regional techniques, other than epidural analgesia, we also have abdominal wall blocks, the facial plane blocks. So we have to consider the patient profile and then consider a combination of techniques that will provide optimal analgesia for the patient, sir.
So now, yes, this is local anesthetic is one side, and then the opioids, NSAIDs, and paracetamol on the step-up ladder pattern.
Yes, sir.
Do you think is there any other drugs can contribute to this multimodal considering the newer trends? These are all traditionally we have been looking at it. Now, there are many approaches have been
So,
come.
when we are planning for epidural analgesia, we can also add adjuvants into along with the local anesthetics, sir. We can add opioids also. We can add drugs like clonidine or dexmedetomidine, and ketamine also can be used along with, sir. And even
Okay,
the same
apart
can be used
from
for IV
uh,
also we can give, sir.
yeah, IV lidocaine and the magnesium also has been practiced in many of
Yes.
the Western institutes where they are looking for non-opioid anesthesia, where they use all these drugs also as a part of multimodal analgesia. Do you know dexamethasone can play any role in this multimodal? Do you have any suggestions?
Yes, sir. Dexamethasone, there have been multiple studies when given IV or along with the local anesthetic, when you combine and give, it has shown to improve the quality of analgesia by prolonging the blockade also, sir.
Yes,
And
now
also
multimodal, yeah.
it also has an anti-inflammatory effect, so the surgical stress and the inflammation can also be decreased with the help of dexamethasone, sir.
So is there any neurotropic drugs you can think of? Not in this particular surgery when you consider multimodal.
What drugs, sir?
Okay, like in many of the
आपने नीचे
institutes, the pregabalin
नहीं
or
नीचे
many
बैठा
other
हूँ ये
drugs has
क्लास
become a
चल
part of a multimodal regimen.
ऐसे ही
So
सुन
the recommendation to all the fellows is to look at the multimodal really, what are all the components, what are all the drugs that we can use, dexamethasone, lidocaine, infusions, pregabalin, magnesium, along with paracetamol, NSAID, opioids on a different range can be a component of multimodal anesthesia. Okay, having said that, your RA strategy being the epidural, can you just elaborate us what could be the nurse that is you're targeting with the epidural? In this particular surgery, what is your surgical innervation? You, can you just tell us?
Yes, sir. Considering this is a laparotomy surgery, so we have to see both the somatic and the visceral component. So somatic component is the abdominal wall incision, so which is, as we can see in the picture, extends from T6 to almost L1. It is a complete midline vertical incision, sir. And the somatic component will be the bowel manipulation that will be done and the bowel dissection that will be done. So my optimal analgesia should combine a plan which will provide analgesia for both the components. So, for the somatic component, I would like to have a coverage of the dermatomal segments from T6 to L1. And for the visceral component, the sympathetic chain, the celiac plexus and superior and inferior mesenteric plexus should also be covered, especially the since this is a hindgut surgery, the inferior mesenteric plexus has to be predominantly covered so that the I get an optimal coverage for the analgesia, sir.
So if you, okay, in the visceral supply, I'm still not getting a clarity. What, for a skin incision, I can understand from T6 to T12. For the visceral pain relief, what is the routes that I need to block?
Yes, sir. This is for this case in particular, sir, since it is carcinoma rectum, and we are looking at the hindgut, sir, and the hindgut is supplied by the inferior mesenteric plexus, which is provided by L1 and L2, sir, nerve roots.
Okay, predominantly the visceral supply, you are targeting the lower thoracic segments, maybe
Yes, sir.
9, 10, 11, 12, L1. So, and then the somatic supply from T6 to T12. Okay, having said that, where you wanted to place your catheter?
Sir, I would like to place my catheter in lower thoracic region, sir, preferably T12 L1, sir, so that I can have somatic coverage above and below, and also the visceral component of the inferior mesenteric plexus in the sympathetic chain is also covered, sir.
Okay, can you just describe quickly that how you will place your epidural catheter? What's the technique that you use? How much you insert? Quickly, can you just tell us?
Yes, sir. With the patient lying in left lateral position, sir, and aseptic precautions, I would like to go ahead with the surface landmark technique, sir. And I will identify the um, intervertebral space based on the Taffier's line L3, L4, and I will count the intervertebral spaces cephalad, and I'll identify the space of T12, L1, and I will local infiltrate with
Is
lignocaine,
the
and then
Taffier's line is an ideal landmark? Is there any concerns with the Taffier's line? Did you?
So there are multiple studies which say that it doesn't coincide with the L3, L4 interspace, sir.
Okay. Then what does it correlate with commonly?
Commonly, it
Okay,
correlates
now,
with
yes.
we tend to the studies are showing that the Taffier's line corresponds to one space above or below, sir.
Okay, it is usually above because the studies which have been looked at the tough years correlation to the central neuraxis is through X-rays, the early studies. When you look at an X-ray, the upper part of the iliac crest corresponds to L4 spinous process or L4 L5 interspace. But in reality, when we do our clinical practice, we palpate the iliac crest, but the skin and the subcutaneous tissue thickness has been ignored when we look at an X-ray. So it easily falls on L4, L5 interspace, but clinically when you palpate, you're always one level above because we don't consider the skin and subcutaneous tissue. Depends on a bigger patients, you may be higher always. So in clinical reality, the tough years line corresponds to L3, L4, not L4, L5. It may be higher, it never been lower. So that is the error with the tough years line. It's okay. So you've identified. Then you use an
Then
LOR to air or saline?
I would use to air, sir.
Okay, how much catheter that length that you wanted to thread in and how you wanted to confirm quick?
Sir, I would like to have a catheter length of 6 centimeter inside the epidural canal, sir. And I would like to test it with epidural test dose with lignocaine 1.5% with adrenaline 5 mics per cc. That is 1 in 2 lakh concentration, sir. And I would like to confirm that the epidural catheter tip is not intravascular or intrathecal, sir. And then I would...
Okay, right. Okay, this is we conventionally used to do. So now you have placed your catheter satisfactorily. How you wanted to dose it up for the intra period?
Yes, sir. Once I confirm the position of the catheter, sir, I would like to activate my epidural with 6 ml of alkalinized 2% lignocaine with adrenaline and wait for at least 10 minutes to establish a definitive level before I proceed with general anesthesia for the patient, sir.
How much lignocaine that you wanted to use?
6 ml, sir. 2% lignocaine, alkalinized lignocaine with adrenaline.
Okay, what is your idea? Because we have many spectrum of local anesthetic. Why you wanted to use a lignocaine? You said you wanted to use epidural plus GA.
Yes,
Why
sir.
you wanted to use this local anesthetic at this particular concentration?
At this particular concentration, lignocaine, sir, it has a faster onset. So before starting the case, we do not have much time to delay. Like if we use bupivacaine, we will require more time to establish the level. And with lignocaine, the effect is faster. We know what level we are achieving with 6 ml also. It is a good volume to have a demonstrable level, sir.
Okay, there is a question in the chat box. Somebody has opined if it's a laparotomy, T7, T8 would be the ideal. Even I thought many of the laparotomy blindly we will look at if you target T7, T8, we will get the both visceral and the somatic supply satisfactorily. What is your opinion? But you selected a low thoracic, and in the chat box, people have preferred it's a mid thoracic should be the ideal or just towards the mid thoracic. What's your call?
Sir, if the surgery would have been a foregut or a midgut surgery, I would have preferred for a mid-thoracic, sir. Considering this is a hindgut surgery, I would like to go for a low thoracic epidural, sir.
Okay, that's okay. So now, what is the concept of the congruent catheter, the surgically congruent catheter and nociceptive congruence? Do you have any ideas about it? Which catheter that you will say that this is perfectly congruent to the surgical stimulus?
Yes, sir. The
And
surgical stimulant
nociceptive
has,
congruence.
as we have discussed before, sir,
Yeah.
the surgery has both somatic nociception and visceral nociception. So when both the nociceptive stimuli are ideally, optimally analgesia dose is given with the least dose and volume of the drug, that will be more congruent, sir. So both the visceral and somatic
Okay.
both have to be covered, sir.
Okay, fine. So now you wanted to use lignocaine so that you can decide before inducing the patient your catheter is working or not, and you wanted to establish the spread, and then you wanted to use that as your benchmark to dose the
Yes, sir.
catheter subsequently.
Yes, sir.
Is that what your goal? Okay.
Yes.
Then how you will maintain the catheter during the intra? You are dosing the catheter with 6 ml alkalinized lignocaine. Why you wanted to alkalinize it? Is there any specific reason for it?
So, alkalinizing the local anesthetic will help in faster action, sir. So the demonstrable level is achieved mostly by 5 minutes. We should be able to have the level, sir. So by maximum 10 minutes, we should be knowing. So that's the reason, sir,
If the spread
to
is
fasten the
between
action.
about T7 to L1, so what you're going to do?
Spread is between T7 to L1,
7 to
sir.
L1. Yeah. So the upper spread is not satisfactory. With the 6 ml, you are assessing at 10 minutes. This is the spread. What is your plan?
So I can supplement with another 3 ml, sir.
Okay.
2%
Then you can,
lignoidia and establish the
and then
level
you
that
can
is needed.
establish
So
the level.
T6 to L1 has to be covered, sir.
Okay, this is the first dose that you are given. The subsequently, how you are going to manage the catheter during the intraoperative period as well as the postoperative period.
Yes, sir. Intraoperative, I would like to go ahead with intermittent boluses of lignocaine with adrenaline, 1% lignocaine with adrenaline, sir, at every 40 minutes. And since 6 ml was not sufficient, then I will add another 3 ml. And if that volume is sufficient, then I will continue with the same volume, sir. Every 40 minutes intraoperatively, I will supplement with 1% lignocaine ADR. Towards the end of the surgery, I will change over to bupivacaine, sir. So I will give one dose of 0.25% bupivacaine, and I will also add about 3 mg morphine also, sir, to the epidural.
Is it
And
towards the end or to begin with itself?
no, sir, towards the end, sir. Throughout the surgery, I would like to use only lignocaine with adrenaline, sir.
Okay, suppose if the surgery, because we have many other local anesthetics, what is the disadvantage or using 0.25% bupivacaine or ropivacaine? We have many other local anesthetics. I thought that if you use a ropivacaine 0.2 percentage, say about 10 ml, considering that you are giving general anesthesia, that will be provide a good hemodynamic stability as well as the endpoint what we wanted. If you're using about 10 ml of 2% lignocaine, won't it affect the hemodynamics?
Yes, sir. We are using a slightly higher volume, 2% lignocaine adrenaline, because our goal is to have complete deafferentation of the nociceptive stimuli, sir. And this will come with the disadvantage of having hypotension also. So, to combat that, I would like to have a noradrenaline baseline infusion, sir, a SVR dose of 0.1, not 1 to 0.05 mics per kg per minute I would run, sir.
You said a word of deafferentation. What do you try to mean by that?
A complete blockade of nociception stimuli to the central nervous system, sir.
So, what do you expect out of it? Is there any specific advantages because you are adding upon vasopressor for the want of doing it? Is it? Do you think is it more beneficial or what is your rationale of doing it?
So the rationale would be that the inflammatory surgical stress response and the insulin resistance that comes with it is all decreased when there is no stimulus perceived by the brain, sir. So that would be the most optimal mode of analgesia than having just analgesia, sir. So this is almost equivalent to anesthesia of the surgical site that is involved, sir.
Okay, then if you use on 1% lignocaine every 40 minutes, the surgery is about 4 to 6 or 7 to 8 hours. How do you calculate your toxic dose and how you are going to manage it? Will you change to any other local anesthetics?
Sir, for lignocaine, sir, the cumulative toxic dose over 24 hours will be almost up to 1000 mg, sir. And we should also see that when every 40 minutes we are giving a bolus. So by the time, say for this surgery went on up to about 10 hours, sir. And the elimination half time of lignocaine is about 100 to 114 114 minutes, sir. So by the end of 2 hours, the first given top up is already half eliminated. So towards the end of the surgery, whatever the doses that we had earlier given has already started going out of the body. So since we are spacing it at intervals, the and if we calculate for this patient, each 6 ml 1% lignocaine will come up to 60 mg, sir. 60 mg, say we are giving 10 doses also, will come to 600 mg. So considering the cumulative 24-hour limit of 1000 mg, we are still giving less only, sir. So we
So
are well within the
to,
limit.
yeah, okay. You said that even with the boluses, there was hypotensive episodes and you need minimal dose of noradrenaline.
Yes, sir.
Can't we think about setting up an infusion and delivering it? Why you wanted to bolus the catheter every single 40 minutes?
So with the epidural infusion, sir, uh, actually epidural analgesia, when we are planning, we are trying to maintain the local anesthetic level in the uh, desired dermatomes. Each time when you give a epidural bolus, sir, there is a transient increase in epidural pressure and there is a spread of the drug in the desired dermatomes, and that level is there and it is acting on the desired level. But when we give an infusion, initially we start with the bolus, the level is achieved, and when you continue the infusion, say about 6 ml per hour, over time, the cephalad dermatomes and the caudal dermatomes, the effective concentration of the drug that is available starts regressing, sir. So the effective level over time when infusion is continued is concentrated to 1 or 2 dermatomes around the tip of the epidural catheter. So the chances of patchy block is increased with the infusion, sir. So when we, in that way, the boluses are better, sir.
So there was a question about if you use a ropivacaine 0.2 percentage with narcotic. You said you have used lignocaine for complete deafferentation. If you use a low potent local anesthetic with narcotic combination, can we able to achieve your goal, or but still you wanted to use lignocaine as your primary choice? 0.2%
Sir,
ropivacaine, 10 ml with 2 mics per ml of, like, how do we use for say labor analgesia, like lignocaine narcotic mix?
um, yes, sir, but ropivacaine for laparotomy I have not used personally, sir. So
Okay,
I
right.
am more
Then
comfortable
you
with lignocaine.
with lignocaine. So you said you will administer morphine at the end. I thought
Yes, sir.
will not it would be useful if you give it before. Is there any do you have specific concern why you wanted to use towards the end?
Mm. Morphine has a long, I mean, it is beneficial in the postoperative period because it provides a long duration of analgesia, sir, almost 12 to 24 hours. Um,
Yeah, okay, that we are looking at only the post-operative analgesia, but as you said, when you try to attempt a complete deafferentation can be achieved with local, but all the multimodal, you said there are other inflammatory soups are going to pour into the systemic circulation. So even though you have a complete deafferentation of the surgical site, it is better to add this multimodal component into the system so that you will control the inflammation as well. They may not directly attribute to the surgical pain, that overall body inflammation can be well under control when you use NSAIDs and paracetamol along with good dose of an epidural. And even if you give that basal narcosis, that is also helpful because it maintains the endorphin levels. And even if you have a patchy segments, that will also contribute to the better pain relief. Okay, now the surgery is over. So here in this concentration, you are aiming at a complete deafferentation. So I wanted all the fellows to think about it, ponder on. It's not only analgesia we are targeting. Parvati is told that she wanted to achieve, in spite of a GA, she wanted to achieve a complete deafferentation. So what is your call on the postoperative? How you are going to use this? The
yes, sir.
epidural catheter.
Post-operative, I would like to change over to bupivacaine intermittent boluses, sir. In post-op day 0 and post-op day 1, I would like to give it at a frequency of 4 hourly intervals. Bupivacaine 0.25%, about 8 ml, sir. And along with morphine 3 mg BD, sir.
So now 0.25 percentage will not produce a sensory motor deficit.
So 0.25% towards the end of the surgery, sir, followed by post-operative 0.15%. I'll decrease the concentration, sir.
Oh, you wanted to give 0.15 percentage.
Yes,
Initially, you
yes.
said 0.25. So 0.15, there was no adjuvants. It is an intermittent bolus you wanted to give?
Yes, sir. Intermittent boluses every 4th hourly, sir. And
Okay.
morphine, I will add twice a day, sir.
So twice a day. What is the dose that you are looking at?
About 3 mg to 5 mg, sir, based on pain intensity.
Okay, right. So if you give an intermittent bolus, how far it is feasible to administer in the postoperative period? Or do you have any system? Because every
So,
fourth hour it has to be give administered. Will you go and
so
administer,
in
or
our
how do you do planning?
In our institution, we have a dedicated acute pain services team, sir, who keeps track of all the epidurals. And we have a regimen of administering bupivacaine boluses every fourth hourly in the post-op day 0 and day 1. And the frequency is decreased to sixth hourly on day 2 and eighth hourly and day 3 and beyond that, sir. So they
So,
tend to
okay,
take
what
care
is
and give the regular
the,
top-ups timely, sir.
yeah, okay, you have an APS system. So can it be replaced with an infusion? What is your comparative pharmacodynamics between intermittent boluses and continuous infusions?
So, as discussed before, the continuous infusions can tend to go into a patchy block also, sir. So, I would still prefer to go with boluses only, sir. And also, considering this is a lower thoracic epidural, there is some amount of motor blockade that may be there for some of the patients. So, with continuous infusion, it is difficult to mobilize the patient or ambulate the patient postoperatively. So, with intermittent boluses, after about say 1 to 1.5 hours from a bolus, we can as well mobilize the patient, sir.
Okay, since the time is very limited, I request all the fellows, we took one and then look at the dimensions. To cover up the other things, Parvati, we have now discussed predominantly a central neuraxial approach. That is good because many of the time this has been ignored, and moment we thought regional fellow that everybody thinks about only parallel nerve block and the facial plane. So I request every fellow to thoroughly understand central neuraxis, and this is one of the core basic area that has been considered. So you should have a clear fundamentals and rationale behind all your dosing regimens and techniques, etc. So quick concluding remarks, Parvati, if you are not able to perform the central neuraxis, there are many other blocks has been proposed. Can you just give us a quick summary of it in about 20 seconds? What other options do we have if you don't have a central neuraxial block?
Yes, sir. Now, coming to the other abdominal wall blocks, the facial plane blocks that are available to provide analgesia for a laparotomy surgery, from the midline, when we come laterally, we can see that we have erector spinae plane block, then there is quadratus lumborum plane block, then there is transverse abdominis plane block, and there is rectus sheath block also. And we can also have infusion wound infiltration catheters also. So literature says there are a few systematic reviews and meta-analysis which have shown that transverse abdominis plane block, especially the lateral or posterior, there is different studies on those with catheters and continuous infusion in the postoperative period, and also rectus sheath blocks have provided better analgesia compared to the other abdominal wall block techniques.
So given the choice, if I wanted to do only one alternative block, which one that you will choose? If you couldn't able to achieve an epidural, which the one block that you choose for a midline laparotomy?
Yes, sir. Post-operatively, the majority of the pain will be because of the somatic components. I would like to secure bilateral rectus sheath blocks, sir, along with multimodal analgesia, which will be continued into the post-operative period also, sir.
Okay, thank you very much, Parvati. We could able to cover up the central neuraxial segments. Thank you very much, Sangamitra. Over to you for further proceedings. Thank you.
Thank you, sir.
Dr. Amjad, can you hear to me?
Yes, I can hear you.
And we can also hear you, sir.
Okay, I'm just going to, trim down this list. Apparently, it looks like a lot of people have joined, but I'm going to limit it down to the participants
Okay.
who have been listed. Just give me a moment. Yeah, can I just remind everyone that this session is only for those who have been selected prior
Sir,
and not,
everyone can listen to you.
yeah. But Sangamitra, a lot of people have joined.
Yeah,
Who
it's
are
a request
the,
for others not to join because this is a very restricted quiz for selected fellows. Please join as a delegate and enjoy the quiz. It will be equally interesting.
Dr. Sangamitra, can you just check if the names of those who have joined are the people that who are supposed to be participating?
Yeah, just 1 second. Kavya needs to join, sir. She's
Yeah,
requested.
she's joined.
Yeah. 1 second, sir. I will
It's
check the
7
list.
people.
Yeah. So we have Priyadarshini K, sir,
Yes.
from Ganga. Then Bhakti Gaude from Ganga. Meghna
Okay.
yes. Meghna, yes, she is there. And Veena, yeah, she's
Yes.
there. Antara,
Yes.
Kavya Sindhu,
Yes.
Gautam Reddy will be missing today, sir. He has some family urgent issue.
All right. So then I'm locking the quiz.
And Meera.
Amira isn't there.
We'll just 1 more minute, sir, and we'll go ahead if
Sure.
Meera joins.
Sure.
Apologies, sir. My audio just got disconnected in between. Shiva sir, it was a wonderful session. Sorry, I had some misconnections of network, so I just got mute and my video was also not popping up. It was a
Yeah,
wonderful session,
yeah.
and especially that the discussion that laparotomy is more about G and block. You have taken it to the central neuraxial was a really important point, sir.
Okay, till Amjad sets up ready, we can, Amjad, you can tell me anytime you wanted to stop. I'll just engage the fellows. So this is quite important information I wanted to share with all of them, that many a time the central neuraxial blocks have been ignored. So I wanted everyone to thoroughly look at the comparative pharmacokinetics and dynamics of various local anesthetics and narcotics inside the central neuraxis, how they are going to use the catheter for surgical anesthesia, analgesia, and when they use along with the GA, what is their rationale? There are various approaches are there. They should have come out with a clear concept, why they wanted to use it and what is their experience. If they know in some of the areas, if they don't have an experience, they should have a clear rationale based on the evidence. So that is what I wanted to emphasize to everyone. Because everybody tell immediately I will do a QL or I will do a tap or rector sheath, but they have not done it. So we are all more doing in central neuraxis, but when the discussion comes, everybody theoretically talks about only a peripheral nerve block. So I request everyone to be strong at central neuraxis. So the tolerance for the examiner will be very less if you do mistakes on the central neuraxial blocks.
All right. Thank you, Shiva. I think we're ready to start.
Okay. Yeah. Okay.
All right. So good evening, everyone. This is going to be a little fun part. We're going to have the Kahoot quiz, and we have 6 participants today with 12 questions. And the questions may not be as serious as you have been discussing earlier. So I think all of you can make out the answers in your mind and we'll get started. All right, so we are good to go now.
Yes, sir.
Amjad, we need music.
Yes, sir. Music, please.
You can play a guitar. Okay, so
So
first
by that,
question is, which of the following is regarded historically as the earliest peripheral nerve block? Supraclavicular, femoral, ankle, or axillary brachial plexus block? Ooh. So 2 people have said supraclavicular, 2 have gone for the ankle, and 2 have gone for the axillary brachial plexus. The correct answer is the axillary brachial plexus block. As early as 1884 by William Halsted, he dissected open the axilla and instilled cocaine on the axillary brachial plexus. The percutaneous method had to wait a couple of decades more, but technically the earliest block in modern medicine is the axillary brachial plexus block. All right, so we'll move to the next question. We'll see who got it right. Meghna answered early, so she's in the lead. So here comes the next question. How many approaches to the intact sciatic nerve has been described? 3, 4, 5, or 6? Okay, nobody got that right. So the trick here is the intact sciatic nerve. So you can eliminate individual blocks along the peroneal, tibial, and the terminal branches. So if you look from top to down, it's going to be the sacral plexus, the transgluteal, the subgluteal, the anterior sciatic, the mid-thigh approach, and the popliteal. So that's 6. And nobody got that. Okay, third question. While performing a popliteal sciatic nerve block, which nerve appears to lie most medial? Peroneal, tibial, sural, or saphenous? All right. So most of you got that right. The tibial nerve is the most medial. If you go lateral, you would encounter the peroneal first. No change in the leader. Next question. What is the characteristic feature of a subdural injection of local anesthetic? Pain during injection, profound hypotension resistant to vasoconstrictors, high sensory and motor block, or failure of the local anesthetic to act? Only one got that right. So when you perform a spinal or an epidural anesthetic, the dura is, especially a spinal anesthetic, the dura is about 250 to 400 microns in thickness, and each layer of the dura is about 5 microns. There is a possibility for the needle to be wedged within these individual layers, and since it's a very compact area, a small amount of local anesthetic can rapidly travel cranially and cause a high sensory and motor block, even with the small volumes that we use. So anytime you're giving a spinal and you find that the block is up to the neck, it is very likely that the injection has gone subdural. So it is characterized by a high sensory and a motor block. Okay, that's the charts for now. According to the new ASRA anticoagulation guidelines of 2025, how many days does the antiplatelet effect of garlic last? 3 days, 7 days, 5 days, or 12 days? So the ASRA guidelines also mentions the use of supplements and their possible effect on anticoagulation, especially their possible interaction with conventional medications. And among them, the 3 Gs that we know of are garlic, ginseng, and ginkgo biloba. All 3 have been known to alter coagulation. Now, should you withhold surgery for a patient who has just had something full of garlic? Possibly not, but just for trivia, I would say the anticoagulant effect of garlic is supposed to last for about 7 days. Okay, Meghna still leading. Easy one. Who invented the Toohey needle? Was it Ralph Lee Huber, Edward Toohey, Robert Stead, or Alan Winnie? Oh my. It's amazing how, little bits of trivia are often missed in our practice. So Ralph Lee Huber is credited with designing what is known as the modern Toohey needle. Ralph Lee Huber in the 1950s was a dentist, and he set out to invent a needle that would possibly minimize the pain on injection while he was injecting into the oral cavity. Edward Toohey, who was a major in the US Army and also an anesthesiologist, decided to use this design to access the epidural space. So while the modified design got the name of Toohey needle, which we all use, Ralph Huber was the one who actually invented the original design, and the patent was in his name. Okay, next question. Nerve block catheters are commonly made with silicone, thermopolyurethane, nylon, or PETG, polyethyl tetraglycol. Which of these materials are commonly used for making the nerve block or the epidural catheter? Oh my. That's strange. Most catheters these days are made from nylon or polyurethane. TPU and PETG are not used within the human body, so that's not going to be the answer. The correct answer is nylon, and most of the cats you see these days are actually nylon. No change still. Which of the following is likely to be the best indicator that local anesthetic systemic toxicity has occurred? Use of ultrasound during the block, pulse oximetry, ECG monitoring, or loss of consciousness in an awake patient. Okay, that's the correct answer. The most important concern we have when the local anesthetic has gone into the blood is that the cardiac system is going to initially get excited and subsequently depressed enough to lead to asystole. So the initial stage of excitation is what we need to catch. So sudden and unexplained tachycardia, hypertension may be indicative of the drug going intravascular. So Meghna still in the lead. Next question. Which of these complications is likely with an interscalene block? Vocal cord paralysis, Horner syndrome, pneumothorax, or superior thyroid artery puncture? Okay, you all got that right. It's Horner syndrome, the triad of ptosis, meiosis, and anhydrosis. It's very common if the local trickles down to the stellate ganglion, causing this. It happens all the time. After a spinal anesthetic, lower limb function did not return in a patient. An immediate MRI revealed this. What is the next course of action? FFP transfusion and correction of coagulopathy, decompressive surgery, epidural saline administration, or reassurance and observation. So only two got that right. So decompressive surgery, especially within the first 6 to 8 hours after diagnosis, has the highest chances of recovery for the patient. As you delay the epidural hematoma and the onset of symptoms, the possibility of recovery worsens. After 24 hours, the chances of recovery are extremely, extremely slim. So the sooner you get this patient into surgery, the better the outcome would be. So the correct answer is decompression surgery. All right, so we have a new leader. Antara is in the lead. And we come to the next question. Which symptom is most characteristic of an intraneural injection? Mild pressure sensation, paresthesia, sharp pain and high opening pressure, or rapid blockade? Most of you got that right. Sharp pain and high opening pressure. We already know that several people recommend measuring the opening pressure when you perform a peripheral nerve block. And sharp pain is again an indicative sign that an intraneural injection is happening. And if you do see your patient experiencing this, immediately stop the injection. Okay, so Antara is in the lead. We have the last question coming up. So if anybody wants to catch up and win this, this is your only chance. How many main branches and sub-branches does the femoral nerve have? 2, 7, 21, 14. Okay, So only one of you got that right. Now, the femoral nerve has multiple muscular branches, multiple cutaneous branches, and subsequently many articular branches. This number of 21 is kind of interesting. You find various sources, but it's somewhere close to 18 to 21 that actually have a name. There may be unnamed branches, but the actual name branches, including the articular branches, kind of total up to 21. So 21 is the answer. Let's see who won this quiz. Third place is Bhakti. Congratulations. Second place is Meghna. Congratulations. And the winner is Antara. Well done, Antara. Well done, all of you. There you go. I hope you enjoyed that.
Antara is a fellow from CAS, Mumbai, under Vushali Punde, ma'am.
Okay.
Congratulations, Antara. And Amjad sir, thank you so much for such a wonderful session. Very simple yet very tricky question, sir.
Thank you, Sangamitra. That's exactly how regional anesthesia is. When you go into the little details of regional anesthesia, there's so much to just doing a block, right? There's a lot of history, there are a lot of stories. If you even look at the story of the spinal anesthetic, it's such a funny and interesting story. So there's a lot of stories in RA, there's a lot of equipment in RA, there's a lot of physics in RA, there's a lot of materials in RA. We can just go on learning about it. And this was just a little touch of perhaps a reminder of what we don't know. And there's so much to know when we deal with RA. Thanks so much for having me conduct this session.
Thank you so much, sir. Thank you. So, moving ahead with our next session, now it's time to play the role by Team Ganga. We always look forward to them, and this time the speaker will be Dr. Senthil sir, joined by fellow Dr. Afrin. And the topic will be, which we always like to learn from Ganga people, is fracture both bone forearm, RA strategy, daycare blocks, ERAS, and Valent. So, welcome, Senthil sir. Dr. Afrin, please share your PPT.
Yes,
Good
ma'am.
evening, everyone.
Good evening, sir.
I
Thank you
hope
for
my
sharing.
slide is seen by everyone.
Yes,
Is
sir.
it visible? Yeah.
Yes. Can you make it full screen, Afrin?
Is it
Yes.
visible, ma'am? Yeah.
Yes,
Good
yes.
evening, everyone. It's a wonderful assembly of the fellows is going on. It's a great discussions going on for the past couple of days. Welcome you all. I'm Dr. Senthil Kumar, consultant anesthesiologist from Ganga Hospital, Coimbatore. Our fellow will be Dr. Afrin, who will
Good
be
evening.
starting with the discussion. The case for us will be a fracture of the both bone forearm. We'll be discussing about what will be the best block, and then afterwards we'll be moving on to what will be the present scenario that is seen in all other places like daycare blocks, ERAS, and Valent. Start with the history. She's a 23-year-old female weighing 65 kilograms. She had a slip and fall at her home, and she has come with her casualty with the complaints of pain over the left forearm. No other injuries. On examination, GCS is fine. No other pain or anything over her body. She has just pain over the left forearm. Her vitals are stable. General examination is fine. The local examination, her pulse is palpable. No loss of sensation, no numbness over the fingers or anywhere in the forearm. Airway is fine. On the X-ray showed both bone forearm over the radius and the ulna. Investigations are fine. She has been adequately starved for the procedure, and then she has been posted on the next day, 8 a.m. And then patient has been wheeled into the preoperative room, and then she is posted for open reduction and plating for the radius and the ulna. Dr. Afrin, what will be your choice of anesthesia? And then you can go ahead.
Yes, sir.
Sir, I have a young patient who is a ASA1 patient without any comorbidity, 65 kgs, and she has presented with a both bone forearm fracture. The plan from the surgical team is open reduction and plating of both bones. First, I'm going to do a pre-op assessment of this patient in detail. Since the patient is posted next day at 8 a.m., I'm going to visit the patient. Introduce myself, and then I'm going to educate her and counsel her about the surgery that she's been posted for the next day. What is the anesthesia plan? I'm going to discuss with her. I'm going to recruit the surgeons as well to discuss their plan. So since we are going to all this plan is basically to make the patient comfortable so that the anxiety patient is not anxious the next day. After educating and counseling the patient, we are going to proceed with taking the consent. I'm going to mark the IV previous day. I'm going to explain her the NPO rules. In our institute, we are practicing NPO to solids for around 6 hours, and NPO to liquids, clear liquids, we allow 2 hours prior to the surgery. The next morning, when the patient is going to be wheeled into the preoperative area, we are going to reassess her with the her vitals that day, confirm the NPO status, and then take a IV line for her. My plan for anesthesia for this procedure, after talking to the surgeons, we have already discussed with the surgeons what is going to be the plan. Since it is a both bone forearm, the incisions that they're going to take, the extent of the incisions, the position of the patients that they're going to do the surgery will be discussed with the surgeons prior. And since it is a both bone forearm, usually there is a volar as well as a dorsal incision that they take for the plating. The patient will be supine position. Since the patient has been counseled about the procedure and she is comfortable to go as an awake procedure without any sedation or mild sedation, I'm going to plan this procedure under regional anesthesia. The plan will be brachial plexus block. The favored brachial plexus block for this case, I would go with the infraclavicular approach, that is a costoclavicular block, sir.
Okay, very good. Very good choice of the block. Why you want to prefer a costoclavicular block? First question. The second will be, what are the other alternatives to costoclavicular block?
First, I'm going to prefer a infraclavicular block. In infraclavicular block, costoclavicular block is going to give me an advantage that it is a superficial block. It is a block which is going to need minimal needling. Like a single prick or maximum two needle pricks will be required for this block. Other than that, the volume that I'm going to use for the local anesthesia will be around 20 ml. It is a phrenic nerve sparing technique. So that is going to help me. I'm going to utilize this as a phrenic nerve sparing technique. Since the patient is going to be supine, minimal sedation will be required for this patient. And other than that, the other techniques that we can use is a lateral approach to the infraclavicular brachial plexus, or the axillary brachial plexus can also be utilized. But there are the costoclavicular has an advantage over the other two techniques. The lateral approach will be more deeper. It will require multiple injections of the local anesthetics. Even with the axillary block, it is a more vascular area. Definitely, abduction of the shoulder will be required in the axillary brachial plexus block. And again, multiple injection. The success rate of the costoclavicular block is more as compared to the other two techniques. So yeah, I'm going to prefer a costoclavicular approach.
Yeah, that's a very good answer. Costoclavicular block as a block in the costoclavicular space, where the nerve groups are grouped together
in a compact
sheath lateral to the artery. And once you position the patient, it will be very superficial with a single needle entry. With a 2-point or 3-point or a single point injection, you can cover all the 3 chords of the brachial plexus. And it is a better option when compared to like above clavicle blocks, where ideal will be a supraclavicular block as it has its own complications, like, as you said, phrenic nerve palsy if the volume exceeds 20, or sometimes in obese patients, even with 20 ml or less than that, we come across phrenic nerve palsy even with supraclavicular block. And other complications like pneumothorax, Horner syndrome, all those things can also be avoided when you do a costoclavicular. With below clavicle blocks, even you can prefer lateral infraclavicular, but it has its own disadvantages. What are the disadvantages of a lateral infraclavicular block, Afrin?
The block is a deeper block, approximately 4 to 6 centimeter deep. Multiple injections will be needed when compared to the costoclavicular. Also, the variations, since the cords in the lateral clavicular fossa, they have rotated around the axillary artery and they have taken the respective position. Multiple injections will be required. There are variations in the position. The position of the cords is not fixed. When it is compared to the costoclavicular, the position of the cords is always fixed. It is always lateral, compactly arranged to the lateral to the axillary artery, which is not the case in the lateral infraclavicular block. So,
yeah, sometimes you might need a dual technique with a nerve stimulator to locate the which cord where it is. Sometimes your artifacts can come in and mislead you in identifying your posterior
no.
cord and medial cord also. And then, is there any nerve sparing, with any chances of nerve sparing with the lateral infraclavicular block when compared to a costoclavicular block, pertaining to the surgery here?
In the lateral infraclavicular
Lateral
blocks,
infraclavicular.
yes, sir.
Yes.
Sometimes there can be axillary nerve sparing can be there, and
Anything important now?
radial nerve can also be spared.
Site of incision. Sometimes musculocutaneous nerve exits.
Musculocutaneous nerve needs to be blocked separately, sir.
Exits,
Since it has already exited.
From the costoclavicular before it comes to the infra. So there is a chance of sparing of musculocutaneous nerve in case of lateral infraclavicular. Not with all patients, but some patients, you can say. Okay.
Yes.
Could you explain the anatomy of the costoclavicular block?
Yes, sir. The costoclavicular space, it is located in the middle third of the clavicle, under the middle third of the clavicle. It is bounded by the clavicle, the first and the second rib posteriorly, with a serratus anterior muscle coming over. Then anteriorly, it is bounded by the clavicle, the subclavius muscle, and the clavicular part of the pectoralis major muscle.
Okay. Could you explain how will you position the patient? What will be the position of the patient? What are the adjustments you do? And the ergonomics of the block?
Yes, sir. The patient will be lying supine with the head tilted to the contralateral side. We prefer to abduct the arm 90 degrees so as to take the clavicle away, lift the clavicle, which is going to give us a better exposure of the cords in the costoclavicular space. The ergonomics will be the machine, the patient, and the operator will be lying in a straight line. It is preferable to stand on the head and side. The operator should be standing on the head and side of the patient, and the machine can be on the same side in a linear fashion.
Okay, that's the same straight line.
Yes, sir.
You will be standing on the ipsilateral shoulder and the probe in line, and then the monitor just opposite to you. What will be your choice of needling? Is it going to be in plane or out of plane? Could you explain the procedure?
We have done this case with an in-plane needling technique, sir. But sometimes the in-plane needling technique the trajectory of the needle can be very steep, and the bony prominences like coracoid process can come in between. So we can also offer an out-of-plane technique, which would be like easier to perform. Either techniques can be done, sir. We have performed this in plane technique.
Okay. When you are scanning a costoclavicular block, any other structures that come into view, and how you negate those structures?
Yes, sir. So when scanning for the costoclavicular block, first we put the probe on the clavicle, and then we slide the probe down and try to insinuate under the clavicle so as to have a look. The sonoanatomy will look like the subclavius muscle and the cords which are sandwiched between the subclavius muscle and the serratus anterior muscle. The subclavius muscle should always be seen in the picture, which is going to give us an assurance that we are in the costoclavicular space. A little towards the lateral side, if we go, we are going to see the pectoralis minor muscle in the picture. If the pectoralis minor muscle comes into the picture, we have to think that we are into the lateral infraclavicular fossa. Another vessels in important vascular structures that are going to come into picture are the cephalic vein, which is going to drain into the axillary vein, and the thoracoacromial artery, which is going to branch out from the axillary artery. So if the cephalic vein or the thoracoacromial artery is coming into the sono anatomy that we are scanning, we are supposed to give a caudal tilt to the probe so as to take that out from uh, the scout scan that we are doing. So the cord should be lying compactly lateral to the axillary artery, sandwiched between the subclavius muscle and the serratus anterior muscle. That is how it should.
You're going to place the what will be the ideal choice of the probe?
The high frequency linear probe, sir, because the depth of the cords will not be more than around 4 centimeters.
So ideal to use a high frequency linear probe. Place your probe over the midpoint of the clavicle and slide the probe caudally and try to tilt the probe so that the grays go underneath the clavicle. Try to find out the first part of the axillary artery and vein medially, and then you try to look for the cords lateral to the artery that are compact. What is the arrangement of the cords? Could you explain the arrangement of how they are arranged?
Most superficially, there will be the lateral cord. Then this is divided into the, according to the cadaveric study, this is basically divided into 2 compartments, sir, the anterior and the posterior compartment. The anterior or the most superficial compartment mostly contains the lateral cord, and then comes the posterior compartment with most laterally lying the posterior cord, and towards the medial side, the medial cord will be lying. And they say there is a thin septa which is separating these lateral cord from the posterior and the medial cord.
What will be your choice of the local anesthetic and the volume?
For this case, we have used 0.5% ropivacaine, sir, around 20 ml with 8 mg dexamethasone as an adjuvant.
What are the other choices if the surgeon says that he's worried about the vascular retain compartment syndrome, other things?
The other local anesthesia
Any choice of
options
short acting or anything?
Yes, sir. 2% lignocaine with adrenaline can be used
Okay.
proximally in this.
How will be your injection? It will be a single injection. Where will you place the needle tip?
For the costoclavicular block, a single injection is sufficient when it is given in between the lateral cord and the posterior and the medial cord. But a dual injection, it gives a better success rate because of the cadaveric studies, which shows that there is a septa which lies between the anterior and the posterior compartment. So dual injections is going to give us a better success rate, and it is recommended. But a single injection can also suffice. We have to make sure that the all the 3 cords are soaked into the local anesthesia when we are seeing this on the USG.
Good. How are you going to evaluate your block?
For evaluation of the block, after giving the block, we are going to give an adequate time for the block to set in. So the soak time, ideally it should be 30 minutes. So 20 to 30 minutes, I'm going to let the block act, and then I'm going to check the sensory and the motor components, whether it is covered, which are required for the surgery. I can use a cold sterilium soaked swab that we use to check the sensations on the required cutaneous innervations if they are covered properly. And other than that, I'm going to check the motor block if it has set in. So all the nerves that I am targeting, that is a radial component, I'm going to check whether the extension of the wrist is possible. We use a pull, push, pinch method, where for the radial nerve, you are going to extend your arm against resistance. Then for the musculocutaneous nerve, you're going to flex the arm, forearm against the resistance. And then we are going to pinch at the base of the index finger to check for the median nerve. And we are going to check pinch at the base of the little finger to check for the ulnar nerve, whether the block has set in or not. This is the easiest way to do it. Other than that, before the surgery, we can ask the surgeons to check before giving the incision. So.
Sure. What is the role of tourniquet? Are you worried about the tourniquet pain and everything?
Yes,
Is
sir.
there a chance of any, let me explain in short about the tourniquet pain?
Yes, sir. So, tourniquet pain is a dull, aching, ischemic type of pain that can happen if, within 30 to 60 minutes of the start of the procedure after the tourniquet is inflated. The tourniquet pain is sometimes not covered because of the regional techniques. It can be resistant to the local anesthetics that we are giving because the tourniquet pain is mostly mediated via the C type of the fibers, which are the slow, dull, pain conducting fibers which are resistant to the local anesthetics, and it is resistant to the ischemia as well. So usually the tourniquet pain we can supplement depending on where the tourniquet is tied. If it is a arm tourniquet, we can supplement the block with the intercostobrachial nerve and the medial cutaneous nerve of the arm can be supplemented. But still, sometimes the patient is going to require analgesics like opioids to minimize this pain. But we should try and keep the tourniquet time within limit to avoid this complication, which is
Do
ideal.
you see it? Have you seen it? Do you see often tourniquet pain during forearm surgeries?
Not really, because what we practice is the limb occlusion pressure, and around 50 mmHg in the upper limb surgeries we add to the limb occlusion pressure, sir. And usually the surgeons will be like they will finish the surgeries within the limited time. So usually they don't go or extend beyond the time. Usually it is not seen, but sometimes it is seen when it is a complicated surgery, and then we supplement with opioids.
So you have to be very careful with the pressure.
Yes.
That is titrated with your systolic blood pressure and the time. And if at all the patient has some discomfort, always go for IV analgesics and IV sedation. That will be better.
Yeah.
Okay. Let's just shift from the forearm fracture to some like daycare procedures or the hand or finger. Okay. The surgeon says he's going to do a daycare procedure or in clinic, a small finger procedure or any carpal tunnel syndrome. He says that the patient will be walking in and then he will stay for an hour or so and then he has to go back to his work or he has to go back to his home. How will you proceed and what are the recent guidelines about ERAS in regional anesthesia? Could you explain about that, Daphne?
So ERAS is basically a multidisciplinary approach which includes the anesthetist, the surgeons, the patient himself, the relatives, and the nursing and the assisting staff in the setup. Basically, the concept is early mobilization of the patients, early discharge to reduce the morbidity and the mortality. Here, what we are going to do is again the education and counseling of the patient with pre-operative optimization of all the comorbidities that the patient has, reduce NPO hours for these patients, so that the surgical stress response, the insulin resistance, and all these factors are reduced. Which brings down the morbidity again and the post-operative stay in the patients. Other than that, ERAS also focuses on the pre-operative antibiotic prophylaxis. It is going to focus on again the optimization and the intraoperative guidelines for the ERAS being the minimal invasive techniques, minimal incisions, less uses of catheters, drains. Even if we put the catheters and drains, we are going to remove them as soon as possible. Since it is any daycare surgery, usually we tend to avoid catheterization. So encouraging bladder voiding before wheeling in the patient to the operation theater is one aspect of this. Then restricted fluid to be given to the patients. This is one aspect of the ERAS. Other than that, post-operatively, multimodal analgesia, which includes IV analgesics, opioid sparing multimodal analgesia is practiced. And other than that, regional blocks needs to be inculcated into the multimodal analgesia that we are giving to the patients. For post-operative early mobilization, early removal of the drains. Other than that, the DVT prophylaxis has to be taken care of. So DVT pumps can be used, and depending upon the other patient factors to be taken into consideration, we can start on low molecular weight heparin as well.
What are the
Physiotherapy and
what are the other
rehabilitation.
indications for a daycare? Any particular patient group or anything like that?
Yes, sir. We need to take into consideration whether the patient is actually fit for a daycare procedure. What is the kind of procedure that he is going to undergo? The patient comorbidities, the patient whether he has any psychiatric illnesses, or whether there is any factor which is going to like some patients will be anxious and will not be very cooperative for the daycare procedures. Then there has to be a lot of social factors also come into picture, wherein the patient has to be accepting of this. There has to be a supporting system, like the relatives have to take care of the patient, and then the surgery is from the surgical side, the duration of the procedure, how long it is going to be, the complexity of the surgery, how it is going to be, the positioning of the patient, all these. So patient factors, surgical factors, and the anesthesia considerations also come into play, whether giving a safe anesthesia should be our priority for this patient. So all these factors needs to be taken into consideration and then tailored as per the patient requirement, surgical requirement, and the anesthesia requirement.
What are the options you have when a surgeon says, the plastic surgeon says that he is going to do a trigger finger release and it's going to take hardly 10 minutes? The patient will wheel in, a patient will just walk in to the OPD setup or a minor theater setup, and then he says that the patient has to go home within an hour.
Yes, sir.
What are you going to proceed?
Here we can go with the concept where the proximal brachial plexus block can be used with a short-acting local anesthetist, and the secondary block can be given to the patients distally. That is the peripheral nerve blocks with a longer-acting analgesic doses, targeting the required nerves distally at the mid arm, forearm, or the wrist level. So this is one option. Another thing is the emerging concept of Valent, that is the wide awake local anesthesia technique, wherein with no tourniquet use, which was introduced by a plastic surgeon from Canada, and it got a lot of popularity during the COVID time, wherein the daycare procedures took a boost. And basically, in the Valent procedure, the surgeon is going to give local anesthesia. 1% lidocaine solution is used in with epinephrine, that is 1:1,000 concentration. So they make a mixture of this along with soda bicarb. In Valent anesthesia, depending on where the surgery is being conducted, usually for this is promoted for the hand surgeries like trigger finger release, or and it is also lately being used
What are the
for
indications? What are the indications of Valent? What are the ideal surgeries where you use it?
for the hand surgeries like trigger finger release. Then it can be used for carpal metacarpal fractures and fixations. It can be used for soft tissue injuries of the hand and forearm, tendon repairs. Lately, in literature, it has been also described for the distal and radius plating. They have used this technique. So they are using 50 ml of 2% lidocaine with 50 ml of NS and 1 ml of epinephrine added to this. The concept being local anesthesia is used along with epinephrine, which is going to act as a vasoconstrictor. And since they are not using any tourniquet for this surgery, the adrenaline is going to help in vasoconstriction and going to give a bloodless field to the surgeon. That is the idea behind this. They are going to inject this mixture in small allocates, starting from skin infiltration to the subcutaneous infiltration, keeping a wheel of around 1 centimeter as they advance the needle forward. And then they utilize a hematoma block when they are doing a distal and radius surgeries. They are using this to give as a hematoma block. So periosteal infiltration of the local anesthetics on the volar side as well as the distal side. From the volar approach, they are also giving local infiltration along the pronator quadratus muscle, which is going to be dissected, and on the dorsal side, in the extensor retinaculum, they are going to infiltrate, and the surgeon is going to carry out this under local anesthesia without tourniquet. The patient is wide awake without any sedation and usually used as a daycare procedure.
Okay, when you do an individual nerve block, what are the potential complications that you can come across?
For the individual nerve blocks, there can be overlap of the sensory supply, basically the overlap of the sensory supply to the area that is being operated. So targeting one individual nerve may not suffice or give us a good surgical anesthesia in that area. So this needs a proper planning about what dermatome needs to be covered, what myotome or what osteodome needs to be covered, and depending on that, multiple injections will be needed for the distal peripheral nerve blocks. So multiple injection is one thing. Overlapping of the cutaneous supply, the myotomes or the osteotomal supply. This is one thing that needs to be taken into consideration. And peripheral nerve injuries can be one complication that we
Yeah,
can
that's also most common thing is that there will be a direct nerve injury with your needle, or sometimes these nerves are usually related to the vessel, so there may be a vessel injury or
vascular
direct injection during the
punctures.
vascular punctures. And these blocks are used without any sedation, so you have to choose the patient accordingly.
Yes.
Okay, I think it's time up. Thank you very much. It was a good discussion. Thank you, Dr. Sangamitra ma'am,
Thank you,
giving the
Sandeep
opportunity.
sir. You have another 2 minutes if you want to finish the talk or to ask something.
That's it. We have to know about the daycare procedures and everything, ma'am. How to choose a patient, and then you have to finish off the preoperative assessment via video conferencing or anything, and then the patient will walk in, and you can reduce your fasting time. Also, the patient can drink clear fluids until you can allow until 1 hour, and then you have to choose the patient wisely because main thing is that you should not use any sedation, short acting blocks, and then the patient will walk out of the minor OT or surgery within an hour. So these are the trends that are coming in, and you have to be very wise. Thank you,
True,
ma'am.
sir.
That's it. That's it.
Thank you. Thank you so
Thank you.
much,
Thank you
Sandeep
very
sir.
much.
Thank you, Afrin.
Very good afternoon.
Will you please share your PPT?
Yes, ma'am.
Moving ahead to last case discussion from Team Mumbai, Dr. Dilip sir will join us with Radhika on case discussion on pediatric inguinal hernia surgery, caudal blocks, pediatric RA versus adult RA.
Is my screen visible, ma'am?
Not yet, dear. Yes. Please start the PPT. Make it full screen.
Yes, ma'am.
Yeah.
Good evening to one and all. I'm Dr. Radhika Ganesh, fellow under Children's Anesthesia Services, Mumbai, under the mentorship of Dr. Vrishali Ponte ma'am. My case discussion for today is a pediatric inguinal hernia surgery. My case, a 3-year-old male child weighing 12 kg, first by birth order, came with chief complaints of swelling over the left groin region, which was noticed by parents since 3 months. The child was apparently all right 3 months back when the parents noticed her swelling over his left groin, which appeared on crying or straining and reduced spontaneously during rest or sleep, and there was no any history of increase and decrease in the size of swelling. There was no history of pain, redness over the swelling, no history of any vomiting, diarrhea, constipation, no history of any increased or decreased urination or any crying during urination. There was no history of any recent fever, cough, and cold. In past history, there was no history of any similar complaints in the past, no positive medical history, and no history of any previous surgical procedures. Coming to birth history, the child was first by birth order, full-term normal vaginal delivery, no history of any NICU admissions. The milestones were achieved on time, and the immunization was adequate. The child, coming to family history, the child was born out of non-consanguineous marriage, and there was no other significant family history.
On examination, general examination, the child was active, alert, playful, and was febrile. The heart rate was 100 beats per minute, and the spine showed normal and no evidence of any deformities. In airway examination, the mouth opening was adequate, and there was no evidence of any obvious facial abnormalities. In systemic examination, the CNS examination was normal. In cardiovascular examination, the S1, S2 was normal, and there was no murmur. There was no visible any scars or sinus over the chest wall and no deformities. The air entry was bilaterally equal and clear and no added sounds. The abdominal examination was normal. The abdomen was soft and non-tender. There was left groin swelling which was present. The investigations were within normal limits. The surgical plan was an open left inguinal herniatomy, and the plan of anesthesia was GA plus caudal block.
Okay, so what will be the dose for caudal block? So how you will be giving the block?
Yes, sir. As it is an inguinal hernia surgery, the dose for a caudal block will be 1 ml per kg. In this case, as the child is 12 kg, so 12 ml of the local anesthetic that we usually use will be given to cover the adequate dermatomes.
Why you give 1 ml per kg?
So we usually follow the Armitage formula for calculation of the drug doses for caudal block, in which the sacral segment usually we give 0.5 ml per kg. For the lumbosacral coverage of the lumbosacral segment, we give around 1 ml per kg. And for if the level needs to be achieved up to the lower thoracic region, we usually give around 1.25 ml of kg. 1.25 ml per kg of local anesthetic.
Okay. Any other modalities what you can give in this? You can consider in a 3-year-old child?
Yes, sir. Other than caudal block, which is usually the best block that we can give in a 3-year-old child, the other blocks that can be given in 3-year-old child is we can give a single shot lumbar epidural. We can also give various.
So when do you prefer to give lumbar epidural? Is there
So
any criteria?
Yes, sir. Sir, actually, by 7 to 8 years of age, when the child reaches up to 7 to 8 years of age, the sacral hiatus is not very prominently felt because of the fusion of the sacral cornua, which is the fifth sacral vertebrae. So it is very difficult to feel for the caudal space in a child who is above 7 to 8 years of age. So in that case, we can go for a single shot lumbar epidural block. And in cases where the weight, the child is very large according to his age and the weight is more, so the volume will exceed the maximum that we can give for the child. So in that case, we can give a single shot lumbar epidural.
Okay, great. So what are the other modalities of like block which you can give in this child?
Yes, sir. The other blocks that can be given are we can give for facial plane blocks like hernia block, which is the block of which covers the L1, that is ilioinguinal and heliohypogastric nerve block. But if we are giving facial plane blocks, we usually prefer giving GA or putting an LMA to the patient when we give facial plane blocks. So hernia block can be given, or same side QL block can also be given as other modalities other than a caudal block or a single shot lumbar epidural.
So what is the second most commonest block what we give is? Apart from caudal, so if you prefer, so which other second modality you will prefer? Either QL or
usually we give hernia block, sir.
Okay. So now consider this child came as a strangulated hernia. Still, you will prefer giving a hernia block or any other modalities? Or obstructed hernia?
Yes.
3-year-old child and then obstructed hernia it comes. So what the plan of action will be?
Yes, sir. In case there is a strangulated hernia, the patient might come for emergency surgery. So there are chances that the incision might extend upwards and it can be converted to a midline laparotomy also, as there are signs of obstruction. So in this case, my plan of anesthesia would be a complete general anesthesia along with an endotracheal tube and muscle relaxant. With that, we can, if we can either give a epidural catheter for this patient along with general anesthesia, or we can give general anesthesia and give like facial plain blocks like QL block.
Okay, so in obstructed, it is better to give either caudal block, because then overall you will see a child, better relaxation will be there,
Yes, sir.
instead of giving any QL block. So that will be that should be the answer for when it comes an obstructed hernia. Let us consider this child is as a 1 month old child. So what
Yes.
will be the plan of action for a 1 month baby for
Yes, sir. I will still go for caudal block, sir. But the things that I should keep in mind is, as it is a neonate, so there are a lot of anatomical and physiological considerations that need to be taken care of. Like in neonate, the dural sac ends a little less lower as compared to older kids. So while giving caudal block, we need to be very careful because there might be chance that we puncture the spinal cord. So usually while giving a smaller bevel needle needs to be used so that a lot lesser length of the needle goes inside before getting caudal block. And another thing is we can still go for a mask. We can keep the child under mask ventilation, spontaneous mask ventilation and caudal block. Just we need to be careful that these patients are at high risk of intraoperative and postoperative apnea due to immature physiology. So these things need to be taken care of, in especially a neonate.
Okay. So why ilioinguinal or hernia blocks are not preferred in neonate? Is there any reason?
So usually we don't prefer because because it's a small child, to during any injury to the vital organs or any viscera can be possible,
No,
because
but
the
if you
structures will
but
be very.
but if you are giving with ultrasound, then
Yes.
like you are seeing all the structures and everything. Correct?
Yes, sir.
So usually in neonates, the caudal block is the gold standard of giving in a hernia cases. Surgeon, there are two reasons which we don't prefer to give hernia block in neonate, because see what happens, you try to give and then there is a displace the structures, or so there is a fluid which is there, and then they are not able to, surgeon finds it difficult to get the sac. So that's why it is better to give a caudal block in neonates.
Yes, sir.
Okay. So okay, this is so any so we discuss, so caudal block is given with the ultrasound and with the blind technique also.
Yes, sir.
So so what are the like how the techniques should we discuss, the Sangamitra, should we discuss the techniques or just only?
Sir, yes, you can.
Okay, so can you explain how you will be Radhika, can you
Yes, sir.
explain the anatomical landmarks for caudal block?
Yes, sir. Yes, sir. So caudal block is usually performed since many years it has been performed by using the landmark technique. So the procedure that we follow is we take the child in the lateral position with the hip and knee flexed, and the parts are painted and draped. So what we see is the sacrum is a kind of is the shape of an inverted triangle. So the base of the sacrum is formed by the line which joins the two posterior superior iliac spine, and the apex of the triangle is formed at the level of the sacral hiatus. So the sacral hiatus is the hiatus which is there between the two sacral cornua, two S5 sacral cornua, which usually fuse at the age of 7 to 8 years. So due to the failure of fusion of these cornua, there is a hiatus. So we look for the sacral hiatus. So the the line between the two posterior superior iliac spine and the sacral hiatus, they usually form an equilateral triangle. So we usually feel the two posterior superior iliac spine with our middle finger and the thumb, and we slide downwards and make an equilateral triangle and feel the sacral hiatus with our index finger, and we leave the thumb, and then we palpate the caudal space using the thumb, and then we insert the needle. So usually we use a 22 gauge needle, 1 inch or 1.5 inch. So we usually the needle is inserted at an angle of 60 degrees from the skin surface, but at an angle of 90 degree with the floor. So once the sacrococcygeal ligament is felt, which covers the sacral cornea, it is felt, we get a pop. So after we get the pop, we just decrease the angle to 30 degree and slightly slide it inwards. That is how we know that we are inside the caudal space. And once we are inside the caudal space, by negative aspiration, we just give the drug.
Okay. So it is a okay. So what drugs you will use in a caudal block?
So sir, the usual
and the concentration.
Yes, sir. The usual drugs that we can use is either we can use 0.25% bupivacaine, 0.25% bupivacaine, either in combination, either as a single drug, or we can use it in a combination of 0.25% bupivacaine plus 2% lignocaine plus adrenaline. So the volumes that we can use is either we can do it half and half, like 0.25%, half of 0.25% bupivacaine or 2% ligno plus adrenaline, or we can take it as 3/4 of 0.25% bupivacaine and 1/4 of 2% ligno plus adrenaline. But first we need to calculate the toxic dose and everything before instilling any drug. And the other drug that we can use is 0.2% ropivacaine as well.
Okay. So any additives you can add?
So usually for hernia surgeries, it usually takes 45 minutes to 1 hour or maximum 1.5 hours. So we usually do not require to add an additive in case of a hernia surgery. But for any prolonged surgeries like hypospadias repair or any orthopedic surgeries, we can add additives. So the most common additive that we use is clonidine, which is usually used in a dose of 1 microgram per kg.
Okay, great. So I think so we covered this hernia. So any other thing, Sanghamitra, to talk?
Sir, if anybody has any questions, we can go for them, or anything else you want to add?
I think so. This is what the common practice, the caudal block, and then I think so everything has been covered in this.
Right, sir, right. So thank you
So
so
any
much.
questions? Yeah.
Any questions will wait for 1 minute, sir. We still have 15 minutes.
Okay.
If there's any question in the chat box. Or the fellows can directly ask. I think the fellows have gone into the... Yeah, we are getting, sir. So from Dr. Lakshmi, do we perform swoosh test for caudal now?
Okay, so usually it was the whoosh test and the swoosh test used to be performed age old, but we usually don't prefer it now because we have the best way actually to know if your drug is going into the caudal space is by negative aspiration and a free flow of local anesthetic, and there is no presence of any subcutaneous swelling by the injection of drug. The other thing is now we have USG to confirm whether our drug is spreading properly into the sacral canal. So this test is usually not performed currently.
Yes. One more question by Dr. Gauri. In laparotomy, is caudal epidural catheters being used? I mean, I think the question is targeted on pediatric population per se.
Yes, ma'am. So, ma'am, caudal epidural catheter can be given especially in very small children like neonates, where the technicality of performing a lumbar or thoracic vertebra, thoracic epidural is a little difficult as compared to the caudal catheter. So, what we do is we can actually put a caudal catheter in very small children like neonates. But what we need to do is we can either measure the level from the caudal space at which you need to want your tip to be. We can either measure it mechanically, or we can just put a catheter and see through USG whether the catheter is going properly into the desired level that you want. But the disadvantages of this is that there is a chance of soiling because of close proximity to the anal opening. This is a chance, and as we are putting it from lower down, so there are chances of it not going into a false space or getting lost during coiling upwards is also a problem. So you can put a caudal catheter in a very small child like a neonate if laparotomy is being done and the patient needs pain relief for 2 to 3 days. But usually in bigger children, we usually prefer putting the epidural at the level which is desired. So thoracic or lumbar.
So I will explain about the epidural catheter. So nowadays we don't prefer to put a caudal catheter. We are very site specific. Even in the neonates, for example, we are doing a thoracotomy. For example, teeth surgery with a thoracotomy. So we put a thoracic epidural even in the neonates also. And if it is a laparotomy, then we put a lumbar epidural. So the sizes of epidural catheter which are available are 20 gauge in the neonate what we put catheter. And since we have a ultrasound, so now regularly everything we do it with the ultrasound. So we come to know exact the position of the catheter also. That is one thing. Secondly, almost for last 15-20 years now we have stopped putting the caudal catheter. But yes, if you are not well experienced, you can use a caudal catheter.
Right, sir. So, last question by Harsha. Do we anal sphincter contractions elicit in practice? If so, at what current amplitude should we accept the response?
Yeah, Radhika, answer.
Anal sphincter response can be done as a PNS with a PNS guided caudal block. So the current is usually around 0.3 to 0.4 milliampere for Ellis.
Right,
Correct.
Radhika. And last question, how do you know if your caudal has acted when your plan of anesthesia is sedation with caudal?
Okay, so we usually practice a lot of not really sedation. So what we do is mask spontaneous ventilation through face mask, and we give a caudal block. So usually what we do is, especially in case of hernia surgery, as we are giving caudal, after giving the caudal block, we just tell the surgeon to just pinch over the space at which they are taking the incision, like the around the inguinal canal. So they usually try and pinch it with a forceps, and we can see response through, and we hold the mask at the same time, so we get to know a difference in any breathing or any leg movement or any movement by the child. So we come to know that caudal has not acted. But in case we are using plain bupivacaine, there might be chances that the action has not yet come, so we can tell the surgeon to wait for a while before starting. That's the reason we add lignoadri, so that the action is onset as compared to using plain bupivacaine. So when there is no response to any the stimulus by the forceps as done by the surgeon, we can assure ourselves that our block has acted.
So there are two ways techniques which we assess the whether the caudal has been acted or not. One thing is you see immediate tachycardia, because we see a baseline heart rate. For example, now child started with 120 or 110 heart rate. Immediately, if it is goes more than 10%, like 140 or something, which we think that then it has not been acted. And simultaneously, since most of these patients are on spontaneous breathing, so there is a hyperventilation which is there. So in that situation, you come to know that okay, it has been not acted. Sometimes it do happen that after few minutes, then there is action is there. So usually we try to surgeon before incision, they try to, with the forceps, they try to pinch. If and then we see whether there is a tachycardia or hyperventilation. And then we again wait for a few minutes and then we start the surgery.
Right, sir. With that, we will come to an end because it will be unfair to ask more questions directly to Radhika. She has answered very well. We will move on to next session of PBLD. But before we shift to PBLD session, Dilip sir, we will just have a small session by Team GE because it goes without saying that this fellowship program has been very well coordinated by them.
Yeah.
Team GE will have a just 2 minutes presentation with us.
Okay. Okay.
Thank you. Thank you so much, sir.
Thank you, ma'am. Thank you, everyone.
Thanks, Radhika.
Thank you, ma'am.
Shweta, can you chip in?
Yes, yes.
Mr. S.N. Sharma is joining us today.
Yes, ma'am, I am there only.
Hi, good evening, Mr. Sharma. Let me introduce him. He is a clinical product manager for point of care of GE India. And thank you, Sharma sir, for letting your team to join us in this session and making this session so much successful. You can please share your screen.
Thank you. First of all, I congratulate all fellows for this engaging session for this RAFA, which is Regional Anesthesia Fellowship Assembly. So, my screen is visible?
Yes, sir.
Yes,
But
sir,
your
please.
full screen.
Okay, so I will take a little bit faster because of the time parameter. So this is very, what focus is not need to tell about. So we are like making a machine which goes to patient basically. So why I am here talking about the AI parameters. So AI parameters is very important today's scenario, like all industries shifting toward this, that save the time of the clinician and the faster way of doing the work as well, right? So we have some product related to that one. So we have the portable one as well. One second. Right. So mobile handheld are there. Logic E, which is laptop type based. We have Venue Fit. We have Venue Go as well. So these are the product which is compatible with the like AI. So one is the our nerve detection with that one. Right. So I will take you on. These are the all special probes are can be attached with the every type of patient from adult, neonatal, and a pediatric patient. Right. We have a special probe also, which is a button probe. You can customize this button and operate from far when you're doing some lot of sterile procedures as well. So why AI? The AI, the one is the EF, automatic calculation of ejection fraction. One is the calculating of collapsibility with the patient. So it will help you to provide you the collapsibility parameter in advanced manner, cardiac output. So that will help you. Once you make a 5-chamber view, it will give you all the parameters in one screen without doing any calculation. Another important factor is calculating of B lines, which is a part of focus and very important, making a panoramic view of the lungs as well, right? And this is for you where the nerve detection is a important parameter. The machine help you in detecting the nerve at the level of brachial, femoral, and sciatic automatically with the video assist on the corner. So you can see how you can scan. So you all are expert on that, but it is embedded in the system. That's all about from my side. So we have lung diagrams, another parameters, EFAS diagram, KUB diagram, having a panoramic view. All these are there with the system. So that will help you in doing your work faster and to make your daily practice in an easy manner. And MSK tools is there to, you can compare the shoulder and with the anatomy you can scan, and my machine will also assess you which part you are looking, which muscles you are looking, the videos embedded in that one. This is to write on the screen to tell about if to some patient or your student what angle you can draw the anatomy, you can mark that also.
right? So, and you can do the raw data process, means you can make the image enhancement later on the stored images also. So as per given me time, not more than 2 minutes, I think my work is done. This is when you fit model. This is when you go. So already we have lot of installation, more than 300 unit installed throughout India. So thank you very much for this. I hope apart from this education factor, we also support in most of the workshop. Thank you, Shetaji, and thank you all doctors for this lot of this engaging session. Thank you very much.
Thank you, Mr. Sharma. I believe you are joined by Mr. Sharad also today.
Sharad is, I think he's traveling outside.
Yeah, I'm there. Can you
Okay,
hear me?
okay. Yes, yes.
Okay. So first of all, thank you, Dr. Dixit and Dr. Diwan and the complete team of anesthesia. We'll continue to support this type of learning platforms and hope you are also seeing the newer technology adoption with the artificial intelligence, what has adopted. And thank you so much. We'll request Dr. Dixit and team to uh, just say a few words on the advantages of the newer technological adoption, one. And secondly, also we'll request that there should be a hands-on workshop who qualifies the questions and the quizzes of this fellowship program. So that will help to the participants to know about and to have a practical experience with the help of ultrasound. So all the best, everyone, and thank you so much.
Thank you so much, Sharath. Unfortunately, Amit sir got stuck in an emergency case. So we will continue our sessions, and thank you, Team G, once again for this wonderful session. Thank you so much. Moving
Okay.
ahead, we are moving at the next but the most important session, which has the maximum numbers of fellow participation. Thanks to Dr. Gaurav Agarwal sir and Dr. Amrita Rath ma'am, we are all waiting for this session. That is PBLD session, problem-based learning and discussion. Welcome Dr. Gaurav sir and Amrita ma'am.
Thank you, Dr. Sangamitra, and
Thank you,
welcome.
ma'am. Good evening, everyone.
So, after the exhaustive sessions, we are going to have a more of a fun and very small portions, like small questions, but I hope that will create more interest in you guys. So, here I have Dr. Amrita here and my co-host, Dr. Gaurav. So, in the next 1 hour, we are going to take you through various questions. So there will be multiple fellows with multiple questions, right? Correct me if I'm wrong, Dr. Gaurav.
Yeah.
So, but we always want it to be impartial. So what we have decided is to pick up the fellow will have chat system so as the fellows and so as the same goes for the questions. So we have 10 questions and the number that the concerned person will get will sell through that question. So with that brief introduction, so let's start the game. So over to you, Dr. Gaurav, for picking the luckiest one for the day.
So the first one I would like to pick up a chit for it's Dr. Ashwati K.
Dr.
Ashwati is
Ashwati.
here.
Yes. Hi, Dr. Ashwati. Welcome. So can you tell me what
She's
is
here.
her cheat
Yeah.
number? Yeah, she is here.
So the question for you is question number 2.
Okay. So the question for you is, did you stimulate? So here goes one of the peripheral nerve. So you have to identify the block being performed. Then let me know the clinical indications. How do you perform the same block step by step, and what is the desired response you would like to elicit?
This is a peripheral nerve stimulator guided obturator nerve block being performed, and The clinical response that we look for is the adductor muscle contractions, and would like to perform the procedure by making the current of taking a current of 1 milliampere and 0.2 second pulse duration, and I would like to insert the needle 2 centimeter lateral and needle to the pubic tubercle, and go in infromedially, and when the adductor muscle contractions are elicited at a response of 1 milliampere, we gradually make the current lesser, and when the response is still present at 0.4 milliampere, I would like to give 20 ml of 10 to 20 ml of local anesthetic.
What is the concentration you'd like to give?
Depending on whether we perform for the procedure, I would like to give 0.5 percentage ropivacaine usually, and it is usually given in procedures like TURBT, where the lateral wall of the bladder would be involved in the tumor.
What are the other clinical indications?
We can also give it for any surgeries that would involve the anteromedial aspect of medial aspect of the thigh, and
Okay, fine. So a bit of addition here. You should always explain the position of the limb that you would like to keep while you perform the particular block.
Yes, I would like to keep the limb a little abducted and the knee flexed a little, 30 to 40 degrees.
Okay, so that's the correct answer. So moving further, can you tell me what is a Rio base?
Rio base is a minimum current that is required to produce an action potential in a nerve.
And what is a chronaxy?
Chronaxy is the pulse duration, sorry, the time required to produce a stimulus at double the Rio base current.
Very good. So why don't we get a pain while you stimulate a peripheral nerve?
Both have different, the chronaxy is different for both sensory and motor nerve. Usually at 0.4 milliamperes, it won't be affected by the sensory nerves won't be affected.
Okay, and I think that is the same reason why we pick up a 0.3 to 0.4 for PNS stimulation.
Yes.
Okay, so have you heard the term, what is sense?
Sequential electrical nerve stimulation, where two impulses are given at one frequency, and the third one would be of a longer duration, so that when we approach the nerve, it would be easier to understand whether we are near the nerve or not.
Dr. Aswasti, what are you missing now? In spite of doing so well, your smile is missing. Okay, so this is what exactly you explained, and you explained very nicely. So this is, you should know, all other fellows should know what is a sense. So this is a newer advancement in PNS. So all of you should know this concept. Okay, so you have been using a PNS. Can you tell me what are the color codes being each of them represent? This is a mustard yellow, this is a lemon yellow.
The lemon yellow would be the current amplitude, and 0.1 is the pulse duration, 2 hertz is the frequency, and 1 kilo ohms is the impedance.
Okay, so as you correctly mentioned, so and the stimulus amplitude is given in milliampere. That is one addition you could have made. Okay, so do you know what are the types of needles and catheters that are being used while performing a peripheral nerve stimulator?
We have insulated needles and non-insulated needles, and catheters. We have catheter over the needle and needle over the catheters. And we usually use insulated needles because it provides an accurate current depth, it won't distribute the current, and we could point the current exactly at concentrate the current exactly at one point.
And what are the what about the catheters? Whether a needle over the catheter is better or catheter over the needle?
Catheter over the needle would be better.
Why?
It would prevent leakage and around the insertion site.
So exactly what you mentioned. So if you use a non-insulated, there will be dissipation of current, but here the intensity at the desired point will be high. So that was why the stimulation will be better. Also, the catheter over the needle will minimize the drug spilling, right? Yes. So I think this is the end of your particular question. Congratulations, you performed very good. So can we move to the next, Dr. Gaurav?
So the next candidate is Dr. Dale.
Dr. Dell, can you unmute yourself?
Yes, ma'am.
Yeah. Your question number is 6.
Are you ready?
Yes.
Here goes your question. So this is a cadaveric image on the left side and right side is an ultrasound image. Have a thorough look over the image. Once you're ready, I will move you to the question. So can you explain this cadaveric image?
Yes, ma'am. It's showing the a section of the neck. So it shows
Is
the
it a section? Is it the section?
cadaveric image. Sorry, cadaveric image of the neck.
After the skin is reflected, this is what you mean.
Yes. So it shows the middle scalene muscle, the anterior scalene muscle. The phrenic nerve has been marked. You see the C5, C6, C7, and C8 nerve roots, and also the sternocleidomastoid muscle.
Okay. So which block is generally performed at this region?
The interscalene block, ma'am.
Okay. So can you tell me the correlation of the roots to the involvement of the phrenic nerve?
So at the C5 level, the phrenic nerve lies around 18 to 20 millimeters from the nerve, from the C5 nerve root. And as we descend down further every centimeter, it moves 3 mm away from the nerve root.
Away, you mean anteriorly?
Yes, ma'am, anterior.
Okay. So what is the implication of knowing this?
So the more distal we go, there is less chances of spread of the local anesthetic to the phrenic nerve, and we can have less chances of the phrenic nerve palsy.
Okay. So can you briefly tell us the course of phrenic nerve?
Yes, ma'am. So the phrenic nerve arises from the mainly the C4 nerve root, and can have contributions. It can have contributions from the C5 and C3 too. So it forms at the upper lateral border of the anterior scalene, and it descends across the anterior scalene. It lies deep to the prevertebral fascia, posterior to the sternocleidomastoid, and then it descends into the neck. In the neck, it lies between the subclavian artery and vein, and then it descends into the thorax to supply both the diaphragms, respectively, the right and the left.
Good. So how do you minimize the risk of phrenic nerve involvement during a interscalene brachial plexus block?
So there are many ways we can do this, ma'am. Firstly, we can one of the ways we can do is to modify the local anesthetic dose, and so we by decreasing the dose, the usual dose of 20 ml can cause around 100% phrenic nerve block. So by decreasing the dose to 10 ml, the chances of phrenic nerve block is almost half, around 60%. Another way is by decreasing the concentration also. A decrease in concentration also can decrease the incidence of phrenic nerve block. Apart from that, the site of injection can also make a difference. So, giving the if you're giving an upper trunk block, if we give it more distally rather than proximal, there is less incidence of phrenic nerve block. So by proximal we mean where the C5, C6 nerve roots they just join to form the upper trunk. Whereas by distal we mean where before the upper trunk divides into the anterior and posterior divisions.
I have two questions here, Dr. Till. First is, what is the MEV 90 for an interscalene block? Minimum effective volume to block in 90% of the subjects.
For phrenic nerve, ma'am?
Yeah. Phrenic, no. For interscalene block, how low volume you can go up to as per literature?
5 to 6 mm.
5 mils, 5.4. Okay. And second thing, can you Can you tell me one trick or one thing which you should take care while performing an interscalene block, else the chance of phrenic involvement will be high, which you didn't mention by now?
Giving an extravesicular or a periplexus injection rather than giving an intravesicular can also decrease the incidence.
That's fair answer. Any still interplexus if you deposited drug towards the anterior scalene. And so you should not cross and go to the anterior part, right? You should try to stay as posterior as possible. Bet the nerve root at the same time. Don't try to spread, right? Okay. So as you mentioned about the distal block, so so this is all what you have already mentioned about extravasal minimizing the concentration and the volume. Okay, what are the phrenic sparing options you can offer to the patient? Any particular block?
Yes, ma'am. For a shoulder surgery, I've already mentioned we can
We
do
are
a
mentioning about shoulder. Let's keep it to shoulder. Yeah.
yes. So we can do a scut block, which is a supraclavicular nerves plus upper trunk. So blocking the only the upper trunk via the methods we just spoke about can decrease the incidence of phrenic nerve palsy. Apart from that, blocking individual nerves like just the suprascapular nerve, either by anterior approach or the posterior approach, along with axillary nerve, is another option. Then we can also do an.
So you mean for that is for analgesia?
Analgesia, yes.
Yes.
And then other options for anesthesia would be infraclavicular or even costoclavicular block, but we'll have to block the suprascapular nerve too with these options.
So if you have to perform an upper trunk block, what are the various approaches?
Upper trunk, there's a proximal approach and a distal approach. So proximal approach would be, like I mentioned, just after the C5 and the C6 nerve roots join. So that's more proximal, whereas distal would be just before they separate into just before the upper trunk separates into the anterior and posterior divisions. So
and anterior, posterior, and SPA.
SPA, yes, ma'am. So the suprascapular nerve and the suprascapular nerve, the posterior and anterior divisions.
So what is the theoretical advantage of distal going a bit distal than the proximal?
We'll have less incidence of phrenic nerve blockage. No?
Yeah. So literature are still inadequate to explain the same, but theoretically that is why I asked if the advantage of one over the other. Thank you so much, Dr. Del, for successfully completing your question. So yeah, so we are again back to Dr. Gaurav.
Yeah, next candidate is Dr. Kaushik. Dr. Kaushik, your question number is, Kaushik is here?
Yes, sir.
Yeah, the question number is 9.
Are you ready, Dr.
I'm also putting a timer for 5 minutes for each question. I'll just put it on the chat. Yeah, can we start?
Yes.
So your question number 9 is handle me now. So this is Mr. San presented to ED with right ankle fracture following a fall at work, underwent a surgical fixation of fracture under RA using a pop sciatic nerve block combined with sedation. Procedure was uneventful. Block was noted to have provided good intraoperative analgesia. 24 hours post-surgery, patient has persistent numbness and tingling, lateral aspect of the leg and foot, weakness in plantar flexion and toe movement. History of nerve block procedure was given to you. 0.5% bupivacaine, 20 mils, ultrasound guided block was done. Procedure was little long duration of 15 minutes. Documentation, the operator noted a paresthesia during the needle placement, but repositioning resolved it before injection. What is your likely diagnosis, the most likely diagnosis?
So first, I would rule out the possibility of prolonging the block duration by the type of the drug and additive that is being used. So the simple block duration would have been prolonged in the first place. And beyond which, if the block additive has considerably weared off or the desired duration is weared off, then we would look for other possibilities, most probably ruling out surgical causes would be from our side would be a nerve injury, peripheral nerve injuries.
Okay. And the history was already given to you that there was no adjuvant used. So what is
Yes.
the duration of block do you expect in a pop sciatic with a bupivacaine 0.5%?
So usually we expect it for based on the site of injection basically. So mostly it is subperitoneal deposition. So we expect it to last around not more than 6 to 8 hours.
Okay. And what is your likely management if it is if you suspect it is already 8 hours and still you don't see any movement and the complaints are persisting? How will you manage it?
Yes, sir. First and foremost is we do a clinical evaluation for this patient and try to rule out all the other sensory evaluation, motor evaluation, and make sure the surgical team is also aware of the concerned situation. And after thorough evaluation, and then we rule out the possibility if it's only a sensory deficit, it's only a sensory mild sensation where patient develops only tingling numbness, we can give a conservative approach to this patient and ask for a follow-up after 4 weeks. And beyond which, after 4 weeks, despite resolution, I mean, if the block sensations have still been persistent, then we expect to do a further neurophysiological imaging to rule out possibility of any other possible nerve injuries. And if at all it is a motor deficits, pronounced motor deficits are present, so we would like to proceed and then evaluate for an urgent electrophysiological studies. So
Okay.
this would be for the management.
And
So the
what is the
other
potential? Yeah, from there, what is the potential mechanism of the nerve injury following a regional nerve block? Or what are the types of nerve injury that you encounter while practicing a regional nerve block? Kaushik?
hello, hello, yes, sir.
Yeah.
Yes, sir. Nerve injuries. What are the potential mechanisms? So basically, the types of nerve injuries are basically classified based on neuropraxia and axonal neurotemesis, and based on Sunderland's classification. I mean, and CDOM's classification and Sunderland's classifications. So, based on the degree of the blockade, I mean, degree of the nerve injury, you might have from ranging from neuropraxia where there is only a myelin injury, or axonal temesis where the axonal conduction and the nerve progression in that region is hampered, or a complete transection of the nerve, such as in neurotemesis, can happen. So, the potential.
What are the steps that you will uh, what are the steps that you will do to prevent such kind of injuries before and after a nerve block?
The first is prior to performing any block, it is imperative to make sure prior nerve injuries are ruled out before you do a nerve block. And after while performing a nerve block, an ideal dual guidance or triple guidance technique needs to be used. And the type of needle that we are trying to use should be a blunt needle, and preferably under ultrasound if possible, try to use an echogenic needle. And we make sure the needle tip is available throughout the course of the block performance. And while using and try to make sure it's not I mean, when you're using a triple guidance, make sure the opening pressure is also being monitored to make sure it's not given high pressure.
Good. And after the block?
So after the block,
how will you prevent? You've given a wonderful block, but there was no signs of nerve injury during the block. After the block, how will you prevent the limb from any further injuries? And the surgeon comes and blames it to your nerve block. How will you prevent that?
after performing a block, you document the important is
Okay.
documentation of the type of block and
Okay. Avoid any compression beyond in the blocked limb. So you will prevent any kind of compression of nerves, any kind of improper positioning of the nerve after the surgery, after the limb after the surgery, which is blocked. So you will take care that the adequate padding to the blocked limb is there to prevent any further injuries. Okay.
This case, pop sciatic, you make sure you adequate pad the heel area.
Yeah. So you've already mentioned this wonderfully. Neuropraxia, axontomesis, neurotomesis, the Sunderland type 1, 2 till 5. And this is the algorithm of management of nerve injury, and you've already mentioned everything wonderfully, and it is for the fellows who are not attending, who are attending to just go through this nerve injury flowchart. And the time is up for this question, so we move to the next one. Wonderful, Kaushik. Thank you. Yeah, we already discussed adjuvants, so adjuvants prolong the block. We'll skip this and go to the next one. So our next candidate is Arya Vishwanath.
Hi, Arya. Can you please unmute
Hello.
yourself?
Yes, ma'am. Good evening,
Hi,
ma'am. Good
Arya.
evening, sir.
Yes.
Hi.
Can you
So
tell
your
us?
question number is 10.
Okay.
Okay. First, you do not panic. So you have a 3-year-old child who brought to the operating room for elective inguinal hernia repair under GA with caudal epidural analgesia for perioperative pain control. The GA is induced uneventfully with sevoflurane and is maintained with a combination of sevoflurane and IV agents. Caudal epidural was given with 0.25% bupivacaine with epinephrine 1:2 lakh as an additive. A total of 20 mils is injected based on the planned dermatomal coverage for perioperative analgesia. So first you quickly help me identify the various structure 1, 2, 3 and what does that image tells you.
Ma'am, so here we are
Arya, can you just
seeing
adjust your camera? That will make the thing more interactive.
1 second, ma'am.
Just turn your screen. We're not able to see you.
Yeah.
Okay, 1 second. Can you see me now, ma'am?
Okay, you're
Yeah?
better. Anyways, not best, but okay, we'll
Okay,
adjust that.
okay. Yeah. So, ma'am, over here, we are basically seeing a transverse scan of the spine at the level of sacrum, most likely below S3. This is a transverse scan of the spine. So what we are seeing is the sacral cornu. This is the classic frog eye sign.
So, do you know
So
how to use annotate to tell me which is a
yes,
sacral
ma'am.
cornu?
This is
Very
the
good.
sacral cornu,
Very
and the
good.
membrane between the two is sacrococcygeal ligament.
Very good.
And yeah, 3 is the once you pierce the membrane, you will get into the caudal space. That is 3. And 2 is the base of the sacrum, followed by anechoic shadow of the bone. That's what we are seeing here.
Perfect. So, can you tell us what is the sign called as?
Frog eye sign, ma'am.
Very good. And what does the right side of the image is talking about?
Yes, ma'am. So this is again longitudinal scan of the spine at the spinal level has been noted here, S3, S4, S5. So here what we see is from superficial to deep, we are seeing the skin subcutaneous tissue.
Yeah,
And
use
then,
your annotate.
yeah, this is skin subcutaneous tissue. And this is the dorsal aspect of the sacrum. And this must be the sacrococcygeal membrane. This is the caudal space. And this is the ventral aspect of the sacrum, S3, S4, S5.
Perfect. Okay. So, which image you'll use when you're doing the out of plane needling and which image you'll use when you're doing the in plane?
So for out of plane needling, I'll be using the transverse section, the transverse scan image, and that will be ideal to locate our site of injection. And to see the spread, the longitudinal scan would be a better option.
So as also you can do a in-plane needling with the longitudinal scan.
Yes, ma'am. Yes, ma'am.
How do you confirm the caudal space and with ultrasound?
Okay. So with ultrasound, ma'am, we have the classic signs that we saw earlier in the image, the frog eye sign at the when you're scanning at the level of the sacrum. Also, if we have to confirm, then we will notice that in the caudal space, you will not see at the level of injection where you are supposed to inject your drug, you will not be seeing dural sac. So if you go more cranially, you will see the ending of your dural sac. Where we are trying not to go. So yeah,
So what will
via
happen if you give LA in the correct caudal space? How do you check if the LA spread is correct?
so yeah, so when you inject the LA in the correct space, the dura will be pushed upwards.
Perfect.
So in the
So
longitudinal.
which dura will be where placed? So we have two duras, posterior dura, anterior dura. Which dura are you talking of?
We are talking about posterior dura.
So where it will be displaced?
Cranially, ma'am.
Means
Cranial
anteriorly.
Yes, ma'am.
Anteriorly, not cranially, anteriorly.
Yeah, sorry. Yeah, anteriorly.
Yeah.
So
what
that's the
is
dural
that?
side sign, ma'am.
Yes, yes. So what are the safety precaution you need to take while you perform an ultrasound guided caudal?
So when we are doing the ultrasound guided caudal, as per the checklist, all the standard safety precautions should be taken. The patient identification,
Yeah, that aura checklist. Okay,
yeah,
that
all the
we know.
checklist
Apart that,
we are
after
supposed
that.
to follow, and sterile precautions should be taken.
No, tell me few caudal specific things.
Okay. So we are handling a pediatric case. So the weight of the child should be known,
The
and we will be
doses.
taking the doses and the volume. The dose and
Dose
the volume.
volume. Next.
Next, dose volume
Which are the
and
patients in which you are afraid of giving caudal?
ma'am, children with suspected spine anomalies, congenital anomalies,
like
spina bifida patients, or children with any Down
Sacral
syndrome. They can have a
HNSS. Not Downs
yes, 3NC
particularly. If there
syndrome.
is a
Yeah.
sacral HNSS, if there is a
Yes,
low-lying dura, if there is a
Yes, ma'am.
tethal cord, so in those cases you should be careful, right?
Yes.
So a pre-procedural ultrasound is a must to rule out these cases. Apart from that,
Yes.
any particular other precaution you would like to take while you perform this? These are very much vascular.
Yes.
So you
So
should.
yeah, so before injecting, I would like to
Always try to frame these questions in patient factors, surgical factors, uh, instrumentation factors or equipment factors, and yours are specific factors.
Yes.
Okay, so
Yes,
that
sir. Yeah.
that ways you remember everything and you can write everything and tell everything in the Viva, because all these type of questions will be time limited.
Yes, sir. Yeah.
So it's not that Dr. Arya, you don't know. You know everything. That
You
even
know
I
everything, yeah.
know.
Just frame it right.
You have to go in a flow so that
Yes,
Yeah.
sir. Yes,
it will
ma'am.
be more impressive.
Yeah.
Yeah.
So
So what happened after 10 minutes you gave the caudal, the ECG initially showed a tachycardia with widened QRS. The child became hypotensive and blood pressure further dropped. Heart rate, just you look at the ECG, it went from 40 to 42 and finally asystole.
Okay. Okay.
So what is the likely diagnosis?
So, ma'am, in this setting, since we have given a caudal epidural block, my likely diagnosis, given the clinical presentation, would be local anesthetic systemic toxicity. Yeah.
Yeah, Amjad sir's quiz has already told you that ECG is the first thing that you need to monitor for last, and
Yes, ma'am. Yes, sir.
you've correctly diagnosed your. Okay. What was wrong here? The next question that ma'am was going
Well,
to ask.
yes, sir. So, while giving the maybe um, um, the we have to make sure that we are not giving intravascular injections. So we have to aspirate in aliquots and then give the drug in
Arya, do
aliquots.
you remember what was the volume that was used and what was the kg weight of the baby?
Ma'am, 20 ml volume was used, and it was a 3-year-old child. Ma'am, I would like to know the weight. Exactly. Yeah.
So suppose I say it's a 10 kg. So the point here is, as you mentioned, intravascular is one likely cause, but before
Yes, ma'am.
that you have to know whether it was a toxic dose or not first. That is why I asked you. So when you answer in your exam, first you go in a stepwise manner. The weight, the volume. We put this question in a tricky way so that the volume should not be an issue, and we wanted you to tell about vascular. But it's not to go You should go in a stepwise manner. This is ruled out. Toxic dose is ruled out. Next, I come to vascular.
Yes,
Okay?
yes, ma'am.
Yes. So how do you manage now?
So now that we are going towards the diagnosis of blast, first will be I will stop if I'm still doing my caudal and injecting my drug. I'll stop injecting the drug, abandon the procedure, call for help, and locate lipid emulsion. Send somebody to get the lipid emulsion. Activate the standard cardiopulmonary code for the hospital, and then also. Uh, then next will be my focus will be on resuscitation. So secure the airway, give 100% oxygen.
How does the last resuscitation differs from any general resuscitation?
In pediatric, ma'am, what happens is most
Not
of our
pediatric.
cases.
I'm asking
Yes,
last.
ma'am.
I'm asking
So
CPR in last
yes,
with
ma'am.
CPR in any patient.
Yes, ma'am. So the dose of epinephrine that we give in last is less. We are supposed to give less than 1 mic per kg, and we also avoid using inotropes like vasopressins, calcium channel blockers. Yeah.
So sodium channel blocker you can give?
And no, sodium channel blockers also you should not be giving because
Because
and
because
and ma'am, local anesthetics act on sodium channel, so you will be further increasing on the
So
toxicity.
can you tell me what is the dose for intralipid?
So ma'am, intralipid, since we're handling a pediatric case, 1.5 ml per kg bolus dose, and 0.25 ml per kg per minute infusion. So the bolus doses can be repeated after 5 minutes to a maximum of total 3 times, and the maximum dose that we can give is 12 ml per kg.
So why it is very difficult to diagnose last in a pediatric patient?
Ma'am, because mostly they are sedated, so you will not have your and they cannot vocalize. You will not have your classic perioral numbness, and they may not have seizures. Mostly, the signs will be initially based on ECG, and then other CNS signs will be not there, not apparent.
Dr. Arya, just when a critical scenario comes, rather than jumping to the definitive management of intralipid, always you need to talk about ABCD.
Yes, ma'am.
Okay, airway breathing, and this babies will be seizuring as well. So you need to have some anti-epileptics or maybe midazolam. Okay, so this is what I wanted you to answer. So thank you so much, Dr. Arya, for your cooperation and answering so well. So, but I
Thank
would
you,
say
Arya.
be a
Thank
bit
you.
more structured. Yeah. Thank you so much.
Okay, so we move to the next candidate is Dr. Harsha, and question is question number 8.
Good evening, sir. Good evening, ma'am.
Hi, Harsha, how are you? So we'll start with solve me. Question number is 8 for you. So she's a 66-year-old, history of fall, reports to ED with pain around hip joint, diagnosis of fracture neck of femur, posted for THR. She had used warfarin 3 days before and had a history of MVR surgery, but did report it during your pre-anesthesia checkup. You decided to perform CSEB. Epidural catheter was administered at L3, L4 space without difficulty. The course was fine, but later on complained of persistent low back pain at 12 hours post-surgery, radiating down her right leg. She reported difficulty walking and increasing numbness in her lower limbs. Vital signs were stable, but she appeared distressed. What is your likely diagnosis and the differentials?
A smile
Sir,
he is very well prepared for this question.
oh, ma'am, I'll try my best, ma'am. In this patient for the THR, we can already see that the patient was on an anticoagulant, that is warfarin, and we did not know about it. So there was no adequate gap between the stoppage of the warfarin and and we went ahead with a neuraxial technique. So my likely diagnosis in this patient would be an epidural hematoma. I can also suspect some other differential diagnosis like an epidural abscess or an anterior spinal artery syndrome. But my primary diagnosis for this would be an epidural hematoma.
Okay. You told that the warfarin was not adequately withheld. So what is
Yes.
the time duration that you would like to withhold the warfarin?
Sir, I would like to withhold for an elective case at least 5 days. And then I would go ahead with the coagulation profile, primarily the INR. I'll check the INR
And
after.
the patient was post MVR. Would you like to do anything else while you're holding the warfarin?
I would like to bridge I would like to bridge the therapy because this is a high coagulation risk patient. So in this patient, I would like to bridge the therapy with
Okay.
either unfractionated heparin or low molecular weight heparin.
Okay, good. So
Harsha, bridging is only recommended if it's a high risk of thrombosis, not in every patient.
Yes, ma'am.
So just a bit of general anesthesia. So it's not that every patient, so we have to see the risk of thrombosis with the risk of bleeding. If it is a low risk of bleeding with a high risk of thrombosis, then only we have to go for a bridging. That too if the patient is on warfarin, not for every patient.
So basically, ma'am is telling that you have to tell about weighing the risk and benefit in such
Yes.
kind of cases.
Yes.
Okay. So what are the main risk factors for epidural hematoma?
So the main risk factors, I would like to divide it in the patient factors. So in the patient factors, I would like to see that the history of the patient, like if the patient is on anti-platelet or anticoagulants, that would be a high risk. Then patients with old age, patients with a history of coagulopathies like liver disease or any other coagulopathies, and we obese patients with difficult spine also may lead to multiple pricks, which may lead to multiple traumatic taps. In equipment or in the procedural factors, I would like to the risk factors would be the basically the number of the attempts and the yes, that's it.
Okay, so basically patient factors, patient with high risk of bleeding on antiplatelet, on anticoagulants, surgical factors you have told, the equipment factors you have told, procedure factors you have told. So what will you do? How will you investigate and what is the intervention of choice?
So my intervention of choice would be directly an MRI. Because in these patients we have a very small window in which we have to diagnose and we have to go ahead if we are suspecting an hematoma. So I would like to do an MRI. Along with that, I would also like to send for a coagulation profile. But my primary investigation would be an MRI.
And already Amjad sir has told in the quiz that what you will do. So can you answer that? What will you do? What is your immediate intervention?
So my immediate intervention, if the MRI shows compression or an epidural hematoma, I would like to go for surgical decompression with neurosurgical reference within 6 hours if we want to avoid further damage.
Okay. So the time for the question is up. We'll just go through the differentials. These are few differentials you've already told, but these are the common differentials for an epidural hematoma and abscess. Uh, it's spinal hematoma, epidural abscess that you have told, anterior spinal artery syndrome you've told, and direct spinal cord trauma. But rest of the things will present suddenly and will have more grave symptoms than an epidural abscess or a hematoma. Okay. So, and abscess will give you a picture of infection and uh, fever and all those parameters will be there. Okay. So, for everyone else, this is the paper that you need to read regarding the same. And we've already discussed warfarin. The latest guidelines, do you know anything about the latest guidelines on warfarin, which was discussed yesterday in the class also?
So in warfarin, we would like if it is not stopped, the warfarin has not been stopped for 5 days, and we are going for an emergency surgery. I would like to assess the INR. If the INR is less than 1.5, then I'll go ahead. If it is more than 1.5, I'll give 4-factor PCC. That is platelet concentrate complex, and along with that, I'll give vitamin K 10 mg IV over 20 to 30 minutes. And
After
if
4-factor, you check the INR again. If
yes,
INR is less than 1.5, you go for the surgery.
yes,
Then give vitamin K if required, if it is more than 1.5. And
yes,
then again, if you don't have 4, you go for factor 3. If you don't have
3-factor
both, you go for FFPs.
FFP.
Okay,
Yes.
this was already covered yesterday, just to show you guys. And suppose the patient was on clopidogrel, how will you
Yes.
manage the same?
So if the patient was on clopidogrel and taken for emergency surgery, I would we would assess whether the risk was whether the surgery is a high bleeding risk surgery or it is a low bleeding risk surgery, and also we would go ahead by taking the consent, explaining to the patient, and go under a platelet cover, that is SDP, single donor platelet or random donor platelets. And along with that, I will give 1 gram tranexamic acid in the like in the preoperative period, and then continue with 1 gram over 8 hours.
What is your anesthetic management?
I'll avoid neuraxial blockade, and I'll avoid deep plexus blocks, and I'll go ahead with general anesthesia.
And do you know any changes in the latest anticoagulation guidelines, antiplatelet guidelines, ASRA 2025?
Yes, sir. So for the anticoagulants, primarily the orally DOACs, they have mentioned that measurement of the plasma levels of all the drugs, that is like apixaban, dabigatran, rivaroxaban, and also the anti-factor 10A levels. So if they are less than, if the drug levels are less than 30 or the anti-factor 10A levels are less than 0.1, so they have then we can go ahead if the drug has not been stopped for the adequate period of time. Apart from that, I think Fonda Parinax also they have changed.
Yeah, so they have changed the low dose and high dose, and accordingly they have changed the
Yes.
stoppage timings for the each drug. And for
Yes.
ticagrelor, they have changed to 5 to 7 days instead of 3 days.
Yes.
Okay, so we'll go with the next question. Our next candidate is Meghna.
Thank you, Dr. Harsha.
Thank you,
Thank you,
Harsha. That was
ma'am.
nice
Thank you,
one.
sir.
Your question number is 7.
Good evening, sir. Good evening, ma'am.
Hi, Dr.
Hello.
Harsha.
Hello, ma'am. Thank
So Harsha, Meghna, sorry. Meghna, you have to tell me why.
Okay.
Sarah, 28-year-old primey, underwent vaginal delivery, 39 weeks gestation, opted for epidural anesthesia. Procedure took longer than usual. Anesthetist reports puncturing of dura. 2 days post-delivery, complains of sudden severe headache, aggravates when upright. What is your likely diagnosis?
Sir, here in this case, I'm going to be suspecting PDPH, post-dural puncture headache, because it is typically coming within 48 hours of the dural puncture, as has been noted in the history. So, yeah.
Okay, so just PDPH. How do you define PDPH?
So this is post-dural puncture headache, which is usually following a accidental dural puncture, either
Okay.
during the spinal anesthesia, the epidural anesthesia, or during any of the procedures, as the pain procedures,
Okay.
which can be. And
Okay.
this is a complaint of the frontal occipital severe throbbing headache, which is mostly postural, aggravated on sitting and decreasing on supine position. Yeah. And since the
Okay.
patient
And
gave
it's associated with neck stiffness
yes, associated with next.
and gets relieved by?
Gets relieved by supination procedure. Supine
Okay.
procedure.
So you've covered all the points. What is the pathophysiology of PDPH?
The pathophysiology usually comes because of the slow leakage of the CSF fluid from the puncture in the dura, and decrease in the pressure of the CSF, causing the vasodilatation of the vessels in the brain. This causes a constant traction on the brain matter, which also causes the pain of the patient, which is usually relieved on the supine position.
Why does it get relieved on supine position?
Due to the like compression in that area, which is like it is exaggerated on stretching of the dural membranes when they are in this sitting position, and while it decreases when they are coming.
Yeah, so the pressure gets relieved, it gets neutralized while
Yeah.
in sitting position. The gravity also acts and causes
Gravitation.
some traction also. And in supine position, it gets neutralized, and also there is some compression, and the CSF leakage slows down.
Yes.
Okay. So what are the risk factors that you know of?
So risk factors usually with respect, we can divide it with respect to patient factors, the procedure factors, and the equipment factors. So in patient factors, which there are high probability is younger age female, and then a previous history of PDPH, and then in needle factors, it usually comes to large bore needle, multiple needle punctures, and cutting needle instead of the blunt tip needle. And in procedure factors, multiple attempts during the procedure, and yeah.
Okay. How will you manage? What are your initial management strategy considered for Sarah?
So initial management here first is reassurance to the patient, and then adequate hydration to the patient, explaining the effects of supination, and also we need to inform her about the consumption of caffeine. So 300 mg per day, usually given as 3 times doses. It helps, and uh, yeah, if the symptoms don't relieve within um, 3 to 4 days, or there is extreme exacerbation of symptoms, we always have to go for like more aggressive management, which can be in the form of the stellate ganglion, the sphenopalatine ganglion block, which is given, and we can give a like the ultimate goal will be epidural blood patch, which is given. So before doing the epidural blood patch, we usually have to assess them if the symptoms are receding. If the symptoms are receding, we won't usually have to go to the
Did you say the stellate ganglion or the sphenopalatine ganglion block?
sphenopalatine ganglion, sir. I was not the stellate ganglion, my bad. Sorry.
So there is a sphenopalatine ganglion block and a occipital also. The occipital block has been shown to have some benefit, but it is inconsistent. Okay, rest of things, caffeine and paracetamol you have told, and NSAIDs you have told. Okay, adequate hydration and everything else you've told apart from reassurance. You will always explain to the patient that it will get resolved within 5 days. And if it doesn't get resolved or it is severe, then we can go
Then
for
we
a
go
blood
for
patch.
the aggressive.
What is a blood patch?
So, epidural blood patch refers to the administration of the autologous blood from the patient into the epidural space. Thus, it acts as a block to the break in the dura, which has occurred during the initial puncture. So, for the procedure, we need to do it in a complete aseptic precaution. So, we have to do it in an OT setup. So, the patient is taken to an OT and explained about the procedure after taking a proper consent and explaining about the procedure. So during the procedure, we have to do it as like the blood has to be collected immediately at the time of the scheduled for epidural blood patch. So aseptic precautions is used around 15 to 20 ml of the autologous blood is collected from the patient, and it is immediately injected into the dural space, especially either preferred to be done one space below the level where the initial puncture was done.
Okay. And how can you prevent PDPH in such patients?
So, so PDPH can be prevented. One, like especially when you're doing a labor patient like this, we prefer to do it in a time when she is not in active stage of labor, as in when she's having a contraction, so that we prevent any of the excessive puncture during that time. Second, we can do by using a smaller gauge needle, as small as possible, and I mean the smaller gauge needle, and using a blunt tip needle like Quinky should not be used, while we use Prote or the Whittaker needles. The newer Penta needles can also be used. And adequate hydration during the procedure, along with the multimodal analgesics like the paracetamol also can be given. and advise the patient to maintain the supine position and not mobilize immediately. And since these labor patients are, they have to feed the baby, so we tell them, give them adequate information that they can feed the baby either in supine position, as in one to the right lateral or left lateral decubitus position, and avoid sitting for prolonged period of time. Adequate hydration has been also advised to these.
Okay, I just saw Hetal sir, so I remembered one question apart from this. If you get a similar picture in a 70-year-old female, what is your likely diagnosis? Having headache after spinal,
Sir,
aggravate.
Aggravates and supine.
In elderly, do we have PDPH? That is what I wanted to ask. Sir had shared a very good article in your fellowship group.
It's usually
If they
not.
don't, then what is the reason? Can any of the fellows answer? Has anyone read? Anyone?
Spinal canal stenosis.
Yeah. नहीं क्या स्माइल कलर स्मेसोस की बोल रहा है the question is clear whether PDPH occurs in elderly.
No,
No.
not
Why?
usually. The tensile strength. No, no.
Okay, so you go back to the paper and read and get back to me. So this is the recommendation given by Vishal Uppal and et al. And the consensus on PDPH. We've already discussed everything, and time is up for this question. I just need you all to go through this carefully before your exams. And you did a great job, Meghna. The last question was googly. Just I saw Hetal sir remembered regarding PDPH, so I asked.
I will read about it,
Okay.
so definitely. Thank you.
Okay, good. Great. So we'll end this question here and we'll go to the next one. Next candidate is Gauri.
Hi, Gauri.
Hello,
Question
ma'am.
is question number
Am
4.
I audible?
Yeah, Gauri, you are very much audible. Hi.
Before Gauri joins, I will like to tell that I enjoy this session most.
Thank you so much, sir.
Thank you, sir. Thank you so much.
After lunch, I mean dinner.
Hi, Gauri. So you have to explore the possibilities. So you have a 28-year-old male who, following RTA, is reported to ED has a multiple rib fracture, otherwise stable, and has in great pain despite conservative management. So the case was referred to you for an intervention for pain management, and maybe you or your friend performed the serratus anterior plane block using ultrasound. You are given good volume. Despite 30 minutes of the block, the patient still complains of pain, clearly indicating it's an inadequate pain relief. So you have the left side as the image as well. So just can you tell me what went wrong?
So, ma'am, there are many factors here we have to consider. One, it can be like here, our block has failed because after 30 minutes of the block, also the patient has not gotten the relief that is supposed to, he should have gotten after a SAB block. So, our first consideration should be, did we select the correct block for the correct location? So
Okay.
here we can see that there are multiple ribs and some ribs are also affected more posteriorly as well.
Very good.
So it could be that the SAB block was not adequate because SAB block covers more lateral as well as the anterior rib fractures. Then another question is, did we inject in the correct plane? Was our technique correct? So
Very
we have
good.
to ponder over that. Was the person who did the block experienced enough? Has he done it before? That should be our consideration.
You
Then
mean
did we select?
inexperienced anesthesiologist, inexperienced RA practitioner.
Yes,
Okay.
ma'am.
So next thing is, did we inject the correct volume in the correct percentage? Say, did we take a very low volume, say 10 ml? 10 ml would not be sufficient to cover this much of a area for the serratus anterior plane block, or did we use a
Otherwise,
very
spatial plane blocks are the volume dependent block.
yes,
is what
volume
you
dependent
mean.
blocks, and did we choose a very low concentration that it is not effective? So these reasons should be explored, and also we should understand that any other injury is also there that can contribute to the non-relief of the pain, like patient factors, like any other injury, any other solid organ injury, or any other anatomical factors like obesity or anything is there, we have to assess.
So perfectly, Gauri, as you mentioned, so here clearly there are few anatomical causes, few surgical equipments, and you mentioned them very perfectly. So you should know the causes of a facial plane block failure. So as of now, you have got this patient. How you are going to manage his pain further?
So we have to explain to the patient that facial plane blocks have sometimes failure, but we have other methods to reduce this pain. So first we have to assess like his numerical pain scale. If he is having very high pain, after giving the paracetamol and NSAIDs as well, we can go for intravenous opioids and patient controlled
Have you
analgesia.
heard about any particular pain scoring for a fracture?
Particular pain scoring.
I mean pain in the sense multiple things to be considered apart from just pain and from
Yes,
according
ma'am.
to.
There are two scores. Like one is the rib fracture score, and another one is the stumble score or the battle score.
So in the
So
sample score, what is the like recommendation above which you should consider for a RA strategy?
the score is about more than 30, ma'am. So in that we consider the patient's age.
Actually, the score is 30. Above 30 is a must, even in the moderate, beyond 11, because you're using opioids. Opioids itself can cause respiratory depression, which is not a very good option in a rib fracture.
Yes,
So
ma'am.
here, early consideration of RA strategy is more important, right? Okay,
Yes, ma'am.
how do you take a call while choosing a block in a rib fracture patient?
So we should assess the if it is a bilateral fracture or a unilateral fracture, that has to be assessed. Then the location of the rib fracture, if it is more posteriorly or it is in the lateral part or is in the anterior part. So if it's in a posterior part, it will be benefited with either a thoracic epidural, thoracic paravertebral blocks, or it can be with the paraspinal blocks like retrolaminar block or erector spinae plane block. If it is the lateral part, we can again we can use all these options along with additional option of serratus anterior plane block. If it is in the anterior or lateral, more in the anterior part, again serratus anterior plane block will be beneficial for such patients.
So, apart from the position of the breakage of the rib, what are the other important thing which you have to also take
We
into
should also assess if we can position the patient that is
Perfect.
required for the
Yes.
performance of the blockade.
Exactly. So, if the patient is able to perform, like roll on to perform, to give a good position for your block. Thank you so much, Dr. Gauri. You did a wonderful job.
Wonderful job. And what is the most common problem that you face in this such kind of a block when doing ultrasound guided block?
Uh, like the plane block, sir, like you're asking about the facial pain.
Yeah, ultrasound guided block you're doing for this patient. What is the most common problem that you'll face? Have you done any rib fracture blocks?
Rib fracture per se I have not done, sir, but these blocks I have practiced. Like,
so in rib fracture fin, what happens? Like
there can be pneumothorax, and that air can be there can be
Exactly.
subcutaneous
Yeah.
emphysema also. So their planes
So
we can't identify.
what will happen if you're putting ultrasound over the surgical emphysema?
There will be we can't the air will not penetrate and we cannot see it properly.
So
So
you got the answer. Thank
yeah.
you.
That's a practical problem. Yeah. Thank you so much, Dr. Gauri.
Thank you, ma'am.
Varnika, next is Varnika. We'll do question number 1.
Good evening, sir.
Are you there?
Yes,
So
sir.
we are short of time. We are skipping one question. So we'll be doing 2 more. So this is the next question. You have to identify the structures and the block performed.
Yes,
You
sir.
can use the annotation to tell me which is what.
Yes, sir.
Do you know how to use annotation?
Sir, ma'am?
Do
Can
you
you
know
use
how
the
to use
annotes?
annotation?
Yes,
There's a
ma'am.
pen on the left
Yeah,
corner.
she's able to use. Yes.
Yeah,
Okay.
yes, ma'am.
Just pick it
So
up
this,
and mark whatever you want, you can identify.
yes, yes, sir. So this is the ultrasound image depicting the femoral nerve block. Here we can see the femoral artery and the femoral nerve lying lateral to the femoral artery, and above the at the superomedial aspect of the iliacus muscle, um,
Okay.
and it lies below the fascia iliaca and the fascia lata, and yes, sir, the skin and subcutaneous tissues.
Okay, great. Can we go to the next slide, please?
Will the
So you've
fascia lata
identified.
and fascia iliaca merge?
No, ma'am, no. The fascia lata comes above, and the fascia iliaca goes below the
That
femoral
is the
nerve. Yeah,
splitting, yes.
yeah, yes, yes.
So you identified these structures nicely, the femoral artery, iliacus muscle, iliaca and lata fascia. What is this rounded structure here?
Uh, lymph nodes, this is the lymph
Yeah.
node.
Okay. So don't guys, don't confuse a lymph node with your femoral nerve because it looks like a bright hyperechoic structure there. Okay. So next slide, you have to identify the landmarks. So this was given by Kijun et al. In a brilliant study that you have to identify all the landmarks before identifying the femoral nerve on the superomedial aspect of the uh, iliacus muscle. Okay. Below the fascia iliaca. Next.
Dr. Vanika, where do you inject, put your injection?
Uh, at the lateral aspect of the femoral nerve, ma'am. Yes, ma'am. Above the femoral nerve, where the fascia, the
Lateral,
splitting of
above, below, lateral to the
lateral, ma'am. Lateral aspect,
So
ma'am.
you
Lateral
right,
aspect of the
stop it
femoral
there.
nerve.
Yes, on the
Yeah.
lateral aspect.
Yeah, so stick to one thing. Don't get confused and bring
Initially, people
unnecessary
used to go
attention to you.
medially. Okay,
Yeah.
people used to go medially. Then above, down, every concept is gone because you can cause a nerve injury. So stay
Yeah.
lateral to it. The nerve
Yes,
will
ma'am.
get paid with time.
So tell
Yes,
us what
ma'am.
are the steps for a successful USGRA block?
To perform a successful regional anesthesia, we should confirm we should confirm the patient information. Like we should collect the proper history from the patient. And if the patient is on any antiplatelets or anticoagulants, the information should be taken care of. And the site of the confirmation should be confirmed. And once we should obtain proper informed consent. We should also inquire about the history of local anesthetic allergy and NPO aspects from the patient. And once the proper documentation has been confirmed, we should make sure the proper ergonomics is set of the and the performer should be in line with the mission. And then after that, the ultrasound settings should be taken care of. The preset should be set appropriately. The selection of the probe should be appropriate, followed by the sterile precautions should be taken care of. The sterile tegaderm should be used, and for proper aseptic precautions, the hand rub 0.4% chlorhexidine should be used. And then the proper dosage and concentration of the LA should be decided. Yes, sir. And then the ultrasound maneuvers, like the proper part maneuvers, should be used for to bring up the appropriate image. Um,
You
yes,
told
sir.
me chlorhexidine 4%. We don't get 4% chlorhexidine. Do you
Sorry,
get the
0.4% with 70%
it is
alcohol.
it is either
Right?
2% or a 10% chlorhexidine. It is never
Oh,
4% or 0.4%.
yes,
We get
yes,
either 2% or a 10% chlorhexidine. So
yes,
just check your facts before you talk. Okay, so we'll just go
yes.
through the preoperative checklist. We'll show you the preoperative checklist. This is prepared by AORA Executive Committee and is available for free of cost. Everyone, for all the members on the website and all RA enthusiasts, you can download and use it regularly. And this is the protocol for a USG guided nerve block. And you've covered everything that consent, preoperative checkup, checklist, minimum standard monitoring. Ergonomics is important while you're doing a USG RA, and selection of a preset probe, sterility, oxygen administration, sedation, sterile precautions, skin infiltration. and holding of the probe, that is again ergonomics, part of ergonomics. Probe should be cleaned and sterile, and you use image optimization using different part maneuvers, then different clinical pulse that you've already told. Okay, so we end this question here, and the last one that we'll do
Thank
for
you
today
so
is
much, Dr. Vanika.
question number 3, and the candidate is Yogesh. Yogesh, you are here?
Hi, Dr. Yogesh.
Yes, sir.
Okay. So you have to identify the block. Oh, sorry. I'm so sorry. I'm so sorry. I'm so sorry. Yes. So you have to identify the block being performed here.
Yes, ma'am. Ma'am,
Can
this
you
is the
please use your
popliteal
annotate?
sciatic nerve
Do you know
block.
how to use the annotate?
Yes, ma'am.
Please use your annotate and tell me each of the structures you
Yes,
can
ma'am.
identify.
So, ma'am, as we can see over here, we can see the popliteal artery and popliteal vein can be seen. Then apart from that, we can see the tibial component, which is the larger component as present. And here we can see the common peroneal nerve, which is present. So this is the popliteal sciatic
Why
nerve
you
block,
told
which
it's
has
a
been.
tibial and this is a common peroneal, one being the larger one then?
Ma'am, apart from that, the fascicles which we can see, as we can see, the more number of fascicles can be seen over here in the common peroneal nerve and lesser in this can be seen in the tibial nerve.
What are the
So
other
that can be
differences?
one of the ways to differentiate.
Yeah,
And yeah, these two, yes.
these two. Any particular location of the thing? Which is more, which is medial, which is lateral?
Ma'am, that because it is not mentioned over here, so we have to see where the marker
Okay.
has been kept, and
Uh,
then we
so,
can decide
uh,
the medial
so
or lateral.
this is lateral, this is medial.
So, ma'am, as we can see, this is lateral, so this should be the common peroneal nerve, and on the medial aspect, it should be the tibial nerve.
Okay, fine. So where exactly to deposit the drug?
Ma'am, usually we should deposit at the sweet spot, which is basically the subparaneural sheath, which we can see, as we can see in this picture also. The drug has been given in the subparaneural sheath, so the drug has been expanded properly, so to cater both the nerves and spread is adequate.
Okay. Having said that, so this is the whatever you mentioned in the ultrasonography, I gave you a structured approach. So you have the numbers. I don't want you to tell all the number, but at least to tell me what is 1, what is 2, what is 9, what is 13, and what is 11. Yes, just tell me this 5, 6 numbers.
So, ma'am, as we can see over here, we can see the muscle fibers can be seen. So this should be the epimysium of the muscle. Then apart from that, as we can see 2. So this is the tibial. This one is the common peroneal probably. So as it is mentioned, so this should be the subparaneural sheath number 2, a paraneural sheath, and number 9 will be the this should be the epineurium. And apart from that, you asked me
So,
number
so you
13.
told, yes, what is first 11, then 30?
Ma'am, 11, because this one is the fascicle, so 11 should be the, this is exactly same, so this should be the 11th is also the same, which is,
Can you just
uh,
focus? Can you just focus? It's a tibial nerve.
yes,
Inside
ma'am,
that, there are multiple fascicles.
multiple fascicles, yes, ma'am.
Fascicle is covered by something.
This is the endoneurium, and inside will be the, these are the axons. 13th will be the axon,
Hmm.
and 11th one will be the and endoneurium or myelin
Hmm.
sheath, maybe.
Hmm.
Endoneurium. This should
Hmm.
be the
So how
endoneurium.
many layers do we have?
Ma'am, starting from the inside, it should be the endoneurium, then perineurium, and then the epineurium will be there.
Very good.
Now,
So nine
what?
being the nine is as you mentioned is your epineurium. Epineurium, right? This is 2 is paraneurium. So 9 becomes your epineurium.
Epineurium.
So
Yes,
if
ma'am.
11 is your endoneurium, where is your paraneurium?
Ma'am, paraneurium is
Perineurium.
number.
Where is the sorry, just correct me. Perineurium.
Ma'am, perineurium is 11th, and 9th is the, first of all, we'll start from the inside. The
Better.
13th one will be the endoneurium,
Hmm.
then 11th will be the perineurium, and then will be the epineurium, which is number 9.
So what is the learning point for you here?
That we should start either from outside to inside or inside to outside, so that we should not get confused.
Before that, have a good look at the image.
Yes, ma'am.
So go closely, see what layer is being deflected one upon the other. So guys, these are jokes apart. This is very frequently asked in your exams. And what is the common observation is most of you get confused with perinurium, paranurium, endonurium, epinurium. So
So
how
this
to
is a must
yes,
know for
must know.
all of you as AORA fellows, and you should go through this article and Dr. Karmakar's article regarding various neural structures and layers. Okay.
Okay, so
Yes.
as we mentioned over here, so if you can see by yourself, they have given each by each layer. Okay, so you have to go one upon the other layer, then you finally call it as endonurium, epinurium, and perinurium. So,
We
what is
have
the importance?
last few seconds left.
Yeah, what is the importance of knowing these layers?
Ma'am, basically because if we are going into the endoneurum or into in the plexus, so these can lead to the damage. Basically, the intraneural injections can be possible, and if we are depositing the drug between the paraneural within the paraneural sheath, so the effect will be faster and lesser chances of the damage to the nerve as well. So we are supposed to
Which layer
avoid
acts
the
as a
endoneural.
toxic drug barrier?
Sorry, ma'am.
Which layer acts as a toxic drug
Yes,
barrier?
yes, ma'am. So usually
Which
the
layer
subparaneural.
acts as a toxic drug barrier?
Ma'am is asking which layer acts as a
Which
toxic
layer
drug.
acts as a.
What is the answer? I didn't get him.
Ma'am, number two, basically, is a paraneural sheath. So, no,
Perineuria.
endoneural, perineurium, perineurium,
Perineuria.
number 9. Yeah.
Okay, then.
Okay. So our time is up. So we can stop here. Sangamitra ma'am?
Yes, sir. Are we finished with all the fellows?
No, we actually cut short it to 10 fellows, but we skipped one question, which was on knee, which was brilliantly covered by Sandeep sir. So we
Right, sir.
skipped that question. We had 10 questions. We had 14 fellows. One did not turn up. So we had to do with 9 only. Rest 5 were left. They have done a mock with us. So they know the questions, the rest of the questions also. And they participated well with us. And I thank them all. We both thank them all for wonderful participation and great work. And all the best to all of you for your upcoming exams. Uh, just keep practicing writing as well as practicals. Always try to answer systematically. In theory, also, you should answer systematically and don't write too much. Write in points. As yesterday, also, all the faculty and mentors have mentioned, just go point wise. Just go make your answers structured with flowcharts, with pointers, with diagrams if required. Label your diagrams. The diagram need not be very artistic. It can be a schematic diagram, but it should be clearly visible and always use big bold letters wherever possible. That is all from my side, and over to you, Dr. Amrita and Dr. Sangamitra.
Yeah, thank you so much. This is all about to say just keep it simple. As Dr. Gaurav told, go in a stepwise manner. Don't jump. Take your time. Think once before you talk. And be careful about the new numbers like 0.2% chlorhexidine. So I know this is a skip of tongue, but if you keep on practicing and talking, I think that will make your life easy and try to bring this thing in your daily work. So whenever you are doing some work, at least you just vocalize before you perform. That will make the things come in your routine and it will be more easy. Over to you, Sangamitra. Best of luck.
And in these last 2 days, we all have realized the fellows have taken immense effort. It's not easy to come up and speak, talk continuously, not referring to anything. I'm really very happy and proud of these fellows who have taken so much effort to go online and talk for continuously for half an hour. So we are really feeling blessed. Actually, I'm really feeling blessed to have such a good batch of fellows. And with that, we come to an end of this session. Hetal sir, you would like
Yeah.
to add something?
Yeah, congratulations to all the fellows and best wishes to all of you for exams. Before we end, can you all of you switch on your cameras and even mics? Request to all fellows. So big round of applause for Sangamitra. She has done all the hard work for last 1 year, and all the classes are possible because of Sangamitra master classes. She has done really very hard work. Thank you, Sangamitra, and keep doing good work. So big round of applause for Sangamitra. Thank you, Sangamitra.
Sir, it's a teamwork. Nothing would have been done if I was not supported by you all. I mean, I have troubled Gaurav sir and Amrita ma'am continuously. You and Amit sir were always there. So it was real teamwork. And thank you so much for the opportunity, sir.
So shall we?
Yes, I think we
close
should
the session?
conclude the session with a special thanks to BOS for this wonderful session. I will share the recording by Tuesday or Wednesday so that the kids can again revise.
Yes.
Thank you all for joining.
And thanks to Team GE also.
Thanks to Team G for this wonderful session. Thank you. Thank you so much.
Thank you. Thank you so much.
Thank you.
Good night,
Thank you so
everyone.
much,
Thank you,
everyone.
ma'am.
Right.
Good night.
Thank you.
Yes, sir.
Okay. Night. Stop recording. Welcome. Shall we end the session?
Yes, we can.